for the fact that it was
Good morning, Dr. Anu, Dr. Satish, Rashi.
Morning.
Morning.
As you told now, I was copying, pasting, tapping,
please
phone.
call them or tell them firstly that it was submitted on the
Good morning, Satish sir.
Morning. Good morning.
the day after.
Day after.
Day after to
So
Mr.
they can,
Anush Sharma.
but if you see, none of.
Pavan,
Elizabeth.
good morning, sir. Pavan would be just joining just now. 1 second, I'll just call him just now. Rashi, good morning, ma'am.
Hi, Elizabeth. Good morning. How are you?
Good.
Thank you.
There is some
Good to meet you
changes.
all.
Only thing is validatory session. We don't have a validatory session today. But the others, there is no change in the program. It's going fine.
Good morning, Dr. Anu. Good morning, Bharat.
Good
Good morning,
morning.
Dr. Satish. How are
Morning,
you?
Rishi. All fine.
Morning,
Morning.
Rashi. Morning, Dr. Satish ji.
Yeah, good morning. Good morning.
Good morning, Narendra. How are you?
Good morning. Good morning, Rashi. Good morning, Dr. Anup. Good morning, Dr. Satish.
Good morning, Narendra ji.
Hi, Pavan.
Hey,
How are you?
Hi.
good, you?
Very well, very well. Thank you.
Thanks. Good
Hello.
morning, all. Dr. Anvika, good morning.
Hello.
Dr.
Hi,
Satish,
Pavan.
good to see you. Hi, Rashi. Hi, Bharat.
Pawan, good to see you today.
Good to see you too.
My pleasure. Morning, Narendra.
Good morning, Bharat. How are you?
All well, all well.
Delhi, heavy rain is there in Delhi?
Not today. Today seems to be a clear day. Are you still in Chennai, Dr. Satish, or gone back to Cochin?
I'm in Cochin.
Cochin, okay.
Yeah. Only
Is it
for
raining
days.
there?
Here it rains, sporadically it rains. Morning was a good rain. Almost 6 months we have rain, yeah.
Yeah. Here we have rain for 2 days and then, we recover for 5 days from the water again.
Yeah.
So, Pawan, is there any specific order that you're thinking of?
Narendra, since you didn't come for that meeting, you're the last one.
Perfect.
No. Actually, I thought instead of randomizing or, the CII folks have given me a sequence here. I mean, they listed the names. So the structure, what I'm thinking was that we discussed the other day was that we start off with me doing the context. I'll probably go around the room for just an introduction, just who you are, title, and this. Then Dr. Anvikar and Dr. Markan from ICMR, probably they would do their opening remarks. And then we do the panel discussion. The sequence that I'm having from the list, it's the same that you got, is Rashi, Rajgopal, Bharat, Narendra, Satish Kumar, and Ravi. Dr. Gaur. Is that okay? But
Perfect.
not necessary. If I'm going to say first question in that sequence, the second question I'll start with the second person and see that, it is like everyone has an opportunity to talk. But flexible, if someone wants to just raise their hand and go, I'm okay with it.
Okay, sounds good.
I think Bharat, Narendra, what we discussed last time was that broadly 4 thematic questions that I thought I will let the panelists answer, and each of you may have a different view. So it doesn't have to be one person, one question, same question, multiple panelists. What's your view on the current situation of diagnostics in India at whatever stage? Each stakeholder may have a different view. One question on what would good look like if you want diagnostics to be an important part of our Ayushman Bharat journey or overall healthcare journey, what good looks like? Each of you, again, because of your backgrounds and because of your experience, may have a different view. What measures we need to do to get to that journey? And one question to each of you on, if you were to be the decision makers in charge of fate of India, what would that one initiative that you would want to do from that goal? The idea is that then I can synthesize that and CII Secretariat can make some recommendations and submit it to the relevant ministry and departments from what we discussed. That's what probably we discussed a couple of days back when we met, and that's what you can expect. I did have a couple of requirements from Dr. Satish saying he wants to focus certain areas, Rashi wanting to focus on certain areas. So from the broad question, if I didn't get that response, then I'll point that question to you and ask to each of you. Feel free to bring that topic up. Again, it's not necessary that I'm the only one who's asking that question. You could just throw it in and we can make it like a discussion.
Super, sounds great.
Does that work?
No, it's perfect. Thanks, Pawan.
Yeah. You and I did a few, so I hope that we will easily be able to maneuver.
Absolutely, that's what I'm used to your moderating style, so I'm absolutely fine.
Dr. Gaur?
Morning, Pawan. Every morning, everybody. Dr. Gaur here. How are you guys?
Hi, Dr. Gaur. Good morning.
Fine, Narendra. Fine, everybody. Fine.
Morning, Dr. Gaur.
Yeah, morning. Hi, how are you? Long time.
Hey, Rajgopal.
Morning, sir.
Morning.
So we have Markan is not there. We have Rashi, Rajgopal, Bharat, Narendra, Satish. So we have all the panelists. I think only Dr. Markan is missing. Elizabeth, I'm hoping you're watching for that. Actually, you based out of NCR or are you in Bombay?
Yes, Gurgaon.
Gurgaon, okay.
Very close to your office, Pawan.
Where is Sefid's office?
It's on Golf Course Road.
Okay.
6.
I'm sorry?
Sector 56.
Yes, you know it.
Tata, my previous company, Apollo Munich, we started in Sector 56,
Ah.
next to the golf course, that building.
Oh, really?
That's
Okay.
where the company started, and we were there for 5 years.
Oh, wow.
Anthony is my neighbor, Rajgopal.
Okay, so he was my CEO for.
Yeah. Anthony's wife and my wife are walking friends.
Yeah, he does call quite regularly. He's a very social person, so
Yeah.
makes it a point.
I think we are kicking it off today. I don't know how the turnout will be. For all you know, we're speaking to ourselves. Dr. Markan, good morning.
Good morning, Dr. Muchiria, and good morning to all the eminent panelists over here. I think we will be going live in another 5 minutes, and we got a very positive response. So I'm very certain that many delegates would have already logged in.
Thank you, Swati. Good morning.
Thank you.
Mocherla, L, not I there. Just a correction from spelling. My name is
Noted, sir.
Mocherla. Yeah.
Dr. Mocheria. Mocherla.
Mocherla. And no doctor. I don't mind taking it, but no.
Okay.
Just a hygiene check question. Dr. Gaur, Dr. Anvikar, Dr. Satish Kumar, would you want me to use doctor every time or can I call you Anu?
No, never.
Is that okay?
Anything. First name is always better.
It's okay.
Yeah.
Thank you. I mean, just checking. Because when someone calls me doctor, I also feel embarrassed and just say, no, please don't. That's a privilege to have, so please don't use it on me. Session title is definitely a tongue twister. I'm trying to see if I can say it without reading the notes, but no, it is not coming out. Good morning, Dr. Markan. My name is Pawan. I'm your moderator for the day.
Yeah, good morning. I hope I'm audible.
Yes.
Okay, fine.
I just took a rain check from our doctor colleagues on the panel. Can I call you Suchita?
Out and mute.
Okay. Probably you hit the mute button, Suchita.
Yeah. I was just having a look at the settings. They are in order.
After the initial intro context, I would be asking Dr. Anvikar and you to do the opening remarks from the policymakers, government perspective, and then we will do the moderated discussion with the panelists who are from different parts of diagnostic industry. Is that okay with you?
Sure, that should be okay.
A very warm welcome to all the delegates and eminent panelists for the second day of the 13th Global MedTech Summit. This is the first session for today, Diagnostic Testing in India, Current Practices, Protocols, Reimbursements, Urgent Need for Paradigm Shift. This panel is moderated by Mr. Pawan Mocheria, Director, India, South Asia, and Becton Dixon, India. Welcome, Welcome, Mr. Mocheria.
Thank you.
We have Dr. Anup Anvikar, Director, National Institutes of Biologics. Dr. Suchita Markan, Scientist, EICMR. Ms. Rashi Garg, General Manager, CFID India Private Limited. Mr. Raj Gopal, Senior Vice President, National Head, ANH Claims, Tata AIG. Welcome, sir. Mr. Bharat Ulipan, Chief Executive Officer, Dr. Lal Path Labs. Mr. Narendra Varde, Managing Director, Roche. Dr. C.S. Satish Kumar, Senior Vice President, Agape Diagnostic Limited. Dr. Ravi Gaur, Director and Chief Medical Advisory Committee, Onquest Lab Limited. Over to you, Mr. Mucheria.
Thank you, Swati. Greetings. My name is Pawan Mocherla. I'm the Managing Director for Becton Dickinson in South Asia. I'm also the Governing Council member for the CII MedTech Task Force. It's a pleasure to be in front of you all, moderating a session on diagnostic testing in India, current practices, protocols, reimbursements, and the paradigm shift that is needed. We have a very good mix of leaders from not only government and policy making, but also from the industry consisting of the lab leaders, IVD company leaders, as well as payer population, payer companies. So we have a mix that could probably talk on where are we today, where do we want to go, and what should we be doing to get to that place. Probably in terms of a brief context before I go through with the structure. The way we do it is that I'll probably start off with a context and then invite Dr. Anvikar and Dr. Markan to have opening remarks. Once the opening remarks are concluded, then we'll do a panel discussion with the members. We all are aware in our experiences of being in India, not necessarily in healthcare, but anywhere in India, that most of the healthcare practitioners do initiate treatment basis symptoms and not diagnostics based as it is done in some parts of developed world. What it has its advantages and disadvantages in a country like India, but a big disadvantage that we've seen evolve over the years is the rampant use of antibiotics and therefore antimicrobial resistance, to name one disadvantage. What it also does is probably not have an appropriate outcome, could be an increased burden on the patients paying for it, both in terms of their quality of health as well as financial. At the same time, diagnostic industry in India is very loosely regulated. There is no one common denominator of quality that you can expect if you go anywhere in the country for a lab. All that is set to change when the government in its latest view has floated Ayushman Bharat as a vision of improving access and healthcare outcomes for across India. And preventive health and diagnostics is a key component of this vision that government is doing. Therefore, it's very, very appropriate that this eminent panel, which is a cross-section of diagnostic industry and healthcare, gets to share their views on what do they see as the way forward and some of the obstacles that we need to overcome. That's broadly the context. With that said, may I invite Dr. Anup Anvikar from National Institute of Biologicals to share his opening remarks. Over to you, Anup.
Thank you, Pawanji, to set the stage for this particular session. First of all, I would like to congratulate the CII for completion of 125 years and also organizing this important summit. And of course, thank you for inviting me to this. Well, this COVID-19 pandemic had taught us many things, and the Indian industry has responded very well to this pandemic. Let it be PPE, let it be any other commodities, and most importantly, diagnostics. Previously, there were very few companies involved into molecular diagnostics, and the cost of one particular test, the reagents for one test used to be in thousands of rupees. Now it's not even 100 rupees. So n number of companies are making the VTMs, then RNA extraction kits, the RT-PCR kits, antigen detection kits, antibody detection kits. So, and we have seen one more thing during the past couple of years. The environment for the diagnostic industry is very conducive. The government is supportive, the regulatory processes are so fast, and everyone is coming together. Yesterday, I was attending this session, and everyone was just supportive of the diagnostic industry, and we should make use of this opportunity and take the lessons learned from the COVID-19 pandemic's response to the other diseases. And we should be involved in making more and more diagnostics for more diseases, and also try to see that the diagnostics are point of care, so that the access to the diagnostic is improved. And even at the primary healthcare settings, we have a number of diagnostics, not just very few diagnostics. While we should be venturing into more and more diagnostics production, so that their quality is also of utmost importance. And in order to ensure better health, quality of the diagnostics is extremely important. Talking about my institute, National Institute of Biologicals, so we have been involved for monitoring the quality of various biologicals, including diagnostics, for the last 30 years. And currently, under our umbrella, there are 275 biologicals, including 171 diagnostics. And every month we are adding more and more diagnostics to our portfolio, and we are open to even the requests from different manufacturers. If you tell us that we are devising such and such diagnostic, and we will be happy to start the monitoring of quality of such diagnostics as well. So I look forward to deliberations further, Pawanji. Thank you.
Thank you, Dr. Anvikar. May I request Dr. Suchita Makhan to have her opening remarks?
Yeah, thank you, Dr. Pawan. It was really nice to hear from the comments from NIB. And we all know that ICMR has played a big role in and at the time of COVID pandemic, when we look at the diagnostic sector, wherein the diagnostic sector is it's not very collated, and there are a lot of gaps which needs to be bridged. But as the mandate of ICMR is to ensure public health and on a larger scale, therefore it was very important at that point in time to have appropriate policies and guidelines in place. The diagnostic devices which are being used had to be validated nationwide, so that the right products are used everywhere and we have the right results on hand. So basically, ICMR in the diagnostic sector has a big role to play at various fronts. It's not only regarding the diagnostics, having appropriate policy framework in place, work joining hands with the diagnostic players across the country. I think more than multiple thousand applications we received, and we had ramped up capabilities of having these kits validated from one center, from with no center to more than 50 centers across the country, so that the right kits are used for doing the validation and testing of COVID. And we also have a lot of programs in hand wherein we provide support to the medical device and diagnostic industries, so that new products also come up. So that's an overarching role we have to play, and definitely nothing can happen if we don't join hands with industry. So ICMR is also now opening up from just promoting R&D to the real science of working in the PPP mode, and with the objective of bringing products to the market. And I'm looking forward to this session and have meaningful discussion, so that we can gauge and have some points on board with us
which will help us to further strengthen our initiatives for bringing products to the market with industry. Thank you.
Thank you, Dr. Markan. Probably now I'll open up for our panelists. I would go in a sequence to start with, and then we will see how we can rotate so that everybody has an equal opportunity. Let me start with Rashi Garg from CEFIT for your opening remarks on this topic.
Yeah, so, Pavan, what Dr. Anup said, what Dr. Suchita said, I think what we saw with COVID, for example, was a huge challenge that the country faced, right? And first of all, my compliments to the government on doing such a fantastic job in ensuring that right from the beginning of the pandemic, whether it was capacity expansion, getting quality tests, ramping up testing capacity in both public and private sectors, I think the government really did a fantastic job. And all of us sitting over here and everybody who's hearing this conversation benefited from it. But having said that, in spite of all the technological advancements that we see globally, I think India still has a long way to go or some way to go. We still struggle with some health challenges. And I think accessibility being one of them. When we talk about small cities, small towns, your suburban hospitals, your rural areas, they still don't have access to quality diagnostics. And then it comes back to symptomatic based testing, comes back to giving medication, which probably they don't need. And hence they don't have access to that quality testing. My big thing is, how do we ensure that we get quality diagnostics, not only in metros and tier 1 towns, but also to those suburban hospitals, to those rural areas. And that's how we will, I think, together, the industry and the government will be able to ensure that we give quality diagnostic healthcare to every citizen of this country, which I think COVID brought out very evidently is eminent, and it's the most important thing we need to be working on. Thank you.
Thanks, Rashi. Let me go to Rajgopal. Rajgopal, what would your views be?
As an insurer who generally comes in after post-treatment, I just want to start by saying traditionally we covered inpatient treatment and we never questioned the treating doctor on treatment protocols or medication or what diagnostics were done. So as a payer, I am sure that going forward, involvement in care management of the patient, even insurers will be part of it, not just diagnostics and doctors and hospitals. We will have some part to play in the specific treatments being given, coverage and things like those. Today, insurers are reluctant to do it because, as I said, a lot of treatment is not protocol driven. So you do not know how to question. The question might be a wrong way to put it, but you will evaluate the treatment being given to a patient. So once the protocols become clear, I can see insurers getting involved in the treatment continuum for the patient. And two, from inpatient, I'm sure it will cover diagnostics, OPD, pharmacy, it will cover a much larger gamut of healthcare expenses. So the way I see the industry growing, our participation increasing in this industry is one, the scope of cover would definitely increase with protocols, standardization, digitization, all those initiatives. And secondly, we playing a part in management of the patient end of the day. Customer is at the center of the whole thing. So whether it's hospitals or diagnostic centers, they do take care. I think we also will participate in managing that. So that's how I see our role going forward. So I'll wait for the other panelists to go ahead and I'll come back.
Thanks, Rajgopal. Let me move to Bharat Uppiliyappan. Bharat, I hope I got your surname right. Why don't we hear your views as part of a large lab leadership that you play?
Thank you, Pavan. Thanks, CI, for having me on this discussion today. I'm really honored. Let me just set a bit of background. So, Pavan, you got my name right. Many compliments to that. At Dr. Lal Path Labs, we are really passionate about bringing quality, affordable, and accessible diagnostics to the length and breadth of the country, and also in other markets we currently operate in. To Rashi's point, we have been making a lot of investments in tier 2, 3, 4 cities. And let me give you some broad coverage of what we really do. Today, there are about 450 or 1 lakh plus towns in India. we cover about 95% of them today through a direct reach. In the sense that today, if a patient wants to come and speak to Dr. Lal PathLab, he will find a way to get across to the patient. We may not have the width of presence in those 1 lakh plus towns, but at least of the 450 plus towns, we are probably 95% of them, including many parts of Northeast, which are typically uncovered. The second thing I want to say is that in the markets where we are really strong in, we reach population densities up to 40K pop strata towns. Now, those of you who may have heard of FMCG distribution may realize that many large companies, which are even listed large multinationals, don't go beyond 1 lakh plus towns. But in many north and east markets, we today reach 40K population towns, which are really going into the hinterlands. This has been made possible by the model we have evolved of a network collection, very strong digitally enabled logistics system, and ability to monitor things at a pan-India level. I would also like to assuage Rashi's observation of getting into more tier 2, 3, 4 cities. More than 60 to 70% of our investments today are devoted to tier 3, 4 cities. That is where really we are seeing the traction coming in because it's an underserved market. Now, when I look at the framework of diagnostics, the three things which come to mind, and I'm not a medical expert, but what I've gathered over the years in this industry, is there are 3 stages: prevention, early detection, and cure. If you look at this paradigm and this continuum, along with a very large population India has, the opportunity in diagnostics is really, really big. So that is part 1. So the real question is, how do we get people to do testing regularly? So there is an issue of coverage of population, and there's an issue of regularity of it. The coverage, like Rashi said, is predominantly in the underserved markets of India, tier 2, 3, 4, and the rural villages. And the regularity issues come in the time-constrained urban population. If you look at this framework of prevention, early diagnostics, and cure, and combine it with coverage and regularity, we possibly start to build together a framework in which we are able to look at what markets need, what kind of solutions. The second point I want to make over here is that India is a very inexpensive diagnostics market. And like the opening doctor said, a cost of reagents have come down significantly, and the way the COVID testing was done from thousands of rupees to hundreds of rupees now. Like we talk of medical tourism, like tourism. In any European, US country today, an RT-PCR test is about $220 plus. It is less than $5 in India. So there's a huge arbitrage opportunity, but that apart, the point is that India has not taken a price increase in diagnostics, or at least we haven't taken for last 6 years. And all that has been done is through volume-led efficiency. And the COVID example is a classic one. Other countries still continue to operate at close to $60 equivalent price point, whereas India is now down to 5. It is all because of volume, the operating efficiencies, and the competitive market forces which come into play. If we have to reach to tier 2, 3, 4 cities, the role of digital as an integral medium of service delivery has to come into play. To a previous discussion with Pavan, what does really good look like and what are the current challenges? I know that the government has done a lot at a central level to ease regulations, especially from an import perspective. However, health is a state subject. And really, it is not even a state subject, it's a district subject. Because the district chief medical officer, the civil surgeon, and the district collector, the district magistrate, are really the ones who determine most of the stuff which happens around healthcare in their geography. They have the ability to grant a permission or withdraw a permission. So really, we are talking of 640 plus countries to be operated in India, and each one of them have varying local regulations at different points of time. So one key submission I have is one country, one regulation. So Pawan, those were my opening thoughts, which I thought I will just share, and we can then build on this further.
Definitely, Bharat. Thank you so much. It starts off a good session when we start. Let me go to Narendra from Roche. Your opening remarks, Narendra.
Thanks, Pawan. Firstly, thank you, CII, for giving me this opportunity to speak. And good to see you again, Dr. Anup. So just from my opening comments, what I would like to share is when we look at our healthcare spending, right, we know it's one of the lowest worldwide. But what is even more shocking is our spending on diagnostics, because our spending is lesser than 2% on healthcare, and then our spending on diagnostics is around 2% of that 2%. So we can imagine that there is a huge scope to start with on first improving our budgets and spending on diagnostics itself, right? Which is something, in a way, with COVID, that attention has come to diagnostics, that now there is that recognition that yes, diagnostics is important. You first need to know before you can treat. And I hope that continues going forward in terms of encouraging policies and regulations um, to invest more in the diagnostic space, right? So that's the first thing that I wanted to share. The second thing is, when we look at technology, diagnostics is a huge space, right? So for the first time, a lot of people, and now even the common man, knows about what an RT-PCR test is. Maybe two years back, no one knew what an RT-PCR test was. Similarly, in diagnostics, there are a lot of different technologies which are at play. You have your point of care testing, you have rapid testing, you have ELISA semi-automated testing, you have fully automated CLIA testing, which is there. There are other areas like immunology, chemistry, hematology which are there. There is coagulation. The point that I'm trying to make is diagnostics is very complex. It's not as simple as it seems out to be, because when you just look at cancer diagnostics, right, there can be serum biomarkers for it, but you also need immunohistochemistry. You also need sequencing and genomics. Then there is digital pathology, which is coming in place. So the second point that I want to bring with this is that we, as a country, also need to understand diagnostics more holistically, in terms of what are the different technologies available and which technology is applicable where, right? And the third one that I wanted to bring in my opening remarks was on regulation, because India is a very unregulated market where diagnostics is there, and that awareness, I think, is already there. And there is something we need to start working on it, because there is no standard care of quality where diagnostics is concerned. And I think a lot of it to blame also is with us and the general population, because when you say go for a blood test, you don't really check where your blood is going. Is it going to a reputed lab like Lal Path Lab, or is it going somewhere, at the back corner and done manually or done semi-automated? You absolutely don't know what result you're getting. Is it really an authentic result that you're getting or not, right? And that's where a lot more regulations are required to drive accreditation, to drive standard of quality where diagnostics is concerned. So I'll touch up more on it later, but that's what I wanted to start with, Pawan. Thank you.
Thanks, Narendra. We're definitely building some themes as we can dive in when probably we finish the opening remarks. May I invite Dr. Satish from Agape for his opening remarks?
Morning, Mr. Pamanji, and thank you, CA, for the opportunity. Current status of utilization of the data, I should say, COVID disrupted the whole aspect of our life. And treatment in terms of patient care, the elective surgery, preventive health care, the mode of consultation, telemedicine, all was in group. So our entire focus was on how to prevent the infections so far. World was grouping in the dark to find solution. At the same time, something else was happening. It was a clear convergence of all the segments of healthcare, which brought research experts together, clinicians, then the diagnostic labs, frontline health workers, medical device companies, pharma people, IT experts, health information systems, all came to a single platform to tackle the virus as one team. In IVD also, it was the emergence of molecular diagnostics as a major diagnostic tool in the testing of COVID. At the start of the pandemic, as we know, we have only very few testing centers in India for R&D only. But now we are having around 1,500 laboratory in India doing private laboratory doing in RT-PCR in India. Then 2,000 plus government institutions are doing the RT-PCR test in India on a daily basis. So RT-PCR and RT-LAMP has become the principal part of the treatment protocol now. And ADN testing is now going slowly replaced by RT-PCR. And awareness of the necessity of diagnostic tools in the modern time has been well established with the corona. And you know, Kerala also right now having daily 1.5 lakhs tests a day, and majority of RT-PCR we are doing every day, even now also. And then doctors were experimenting with the many drugs like hydroxyquinone in the beginning, but later on when we come with the prognostic tools like DDMR, CRP, ferritin and all, now the protocol has been modified and in place. Thus, COVID has brought all the healthcare professionals and IT and government and ICMR, CDSCO, all the same platform, with the emergence of good diagnostic tools on molecular biology platform. At the same time, newer research on molecular biology is happening now on other infectious diseases. And vaccination has been developed within a short record time. And but government has not taken the note of the huge capacity upgradation of our domestic industry, especially medical industry during this pandemic. When there are big gap in supply, we could all make things faster. So convergence of all the stakeholders of healthcare, IT, government will be the need of the hour. And again, as previously Ravi Gopal told, we need insurance benefits to be all preventive diagnosis and pre-diagnosis, disease diagnostics in India. And again, the regulatory framework should, as I told, that ICMR, NABL, NABH, CDSCO, ISO, ICMR, a lot of things are all there. So I can have some better clarity and uniformity. So these are all, I think, my thoughts on this.
Thanks, Dr. Satish. Let's bring it home in terms of opening by going to Dr. Ravi Gaur from OnQuest.
Good morning, everybody. I think thank you, Pawan, and thank you, CII, for giving me the opportunity to talk on this very important topic today. One thing is I like to start with, without diagnostics, the men of science are soldiers without arms. That's, I think, the very first point I like to say, because it was earlier like with all the pathologists or everybody was just sitting behind the microscope. We were always like the benchers. The COVID has made us to be the front foot guy. We are the front. I think that's the biggest change which is happening, and that's a very nice, because now we are moving towards evidence-based kind of a practice, and it's not like hitting on the differential diagnosis by clinical examination, and that's a very positive sign, and that's a thing which is, I think, diagnostic industry is heading for, and this is where the opportunity lies for all of us. The two important things that I think I'll probably, from the diagnostic point of view, we decide that, we have AC and BC probably, like, no more. It will be like, after COVID and before COVID. That's what it is going to be an era for us. So it's not like after Christ, before Christ I'm talking about. It's like just what will happen post-COVID and after COVID and before COVID, what happened. I think things have dramatically changed. And the diagnostic industry, especially the pathology labs, have proven that their worth. It was not like people are getting testing done for no reasons at night, but no, it is worth. It really takes help, and biggest change has happened in the minds of the people, because they have. Narendra has mentioned earlier, like he's talking about RT-PCR. Everybody knows about RT-PCR. The importance of technology has come up further, because now the importance of technology, and technology pricing can be brought down. The volumes are good, and you apply it correctly. So the PCR as a technology is probably going to give a reveal much, much more. Earlier, PCR was being used to start with some oncology specific, then it moved on to infectious disease, and that too probably a very high cost and some skilled platform. Today, it is almost like, you have about 2,800, 500 ICMR or NABL approved RT-PCR labs, and every common man, even the GP knows next door, get an RT-PCR test done. Now they know we should take this forward, what PCR technology can do forward. PCR can do wonders because different technology. But technology is definitely now in the forefront, and the need is to make sure that right utilization of technology and volumes are there so that we can deliver better at the for the people who are actually deserving probably the bottom of the pyramid. Those people are not been able to probably access to the technology. Then comes, you can say that, one second point, what I've noticed actually, see, in my college time or probably when I was my undergraduate, so our teachers used to say you're tidy and clean. Tidy labs are mean that you're not work. Tidy desk is means you're not work probably. It's the lazy kid scientists are working in the lab. But today it's no. I think tidy man lab means spick span, fully automated, and that's where I think the technology is again. So another thing is happening in technology, in the diagnostic is automation and integration basically. Totally integrated together because it's not like standalone testing I'm doing. I have to integrate what my because with the clinicians, with the radiologists, with the diagnostic people, all three of us have to speak in a single language to arrive at a diagnosis. Because otherwise, it was clinician was examining, giving his own diagnosis. He was just using the diagnostic report as one of the tool, still making his own decision. Of course, he is still entitled to do that. But I think the integrated diagnostic is going to play a very, very important role as we move forward in the future. Now, three segments probably what we talked about. It was diagnostic was always like into the illness based probably. Somebody has a symptom and then comes to a doctor. But today, no. I think there's a dramatic change. We have seen actually in the practice people used to come for 5-7% people or the entire diagnostic tests which are being done. What are the preventive check? But I think that number has gone up to 17-18% today. Awareness come up. People who want to know something about themselves. So anyway, there are areas where we have to work on early diagnosis, a preventive diagnosis or a predictive diagnosis, and even the areas of biomarkers and wellness, because the lifespan has gone up. You must have seen the average and the people are now living up to almost 78 to 80 years. So from 65 to 80 years, when most of the NCDs are there, people can afford the testing. They still may be suffering from NCD, diabetes, hypertension, and other disorders, but they want to feel well. So the various biomarkers of wellness is another area which is now going to be seen as we move ahead. So I think, and lastly, the testing, the paradigm shift which is happening is what Bharat has mentioned, like tier 2, tier 3, because its area is no more era of centralized diagnostics. Centralized will be important for a specialized super specialty, newer testing, where the turnaround time is not that important. But I think near patient, point of care testing, as close to as testing is possible, and the turnaround time, because a missed report means you have missed the patient, because everybody wants a faster report, a quicker report, at least an indication to start treatment. So point of care devices or a near patient device industry, that is going to be very, very important. Overall, probably I'll feel that it's going to be an era of personalized diagnostics, and think we have proven our diagnostic guys, we have capabilities, some regulations, some more support from the government, and I think the industry, devices, and insurance people, we will be there where we are desiring and looking forward to. That's what I want to add.
Thanks, Dr. Gaur. I think at least the broadly some themes that emerge from each of your views or stakeholders' views, which is around the spread, which is around the consistent quality of diagnostics that is available, some kind of a regulation. Probably we will delve a little deeper. What would we mean by that? Some kind of regulation, because what is good for some may not be good for others. We also looked at what kind of technologies probably this market would have. Let me start with Dr. Gaur and go in a counterclockwise so that everyone has the opportunity of not needing to wait for a long time to share their view. Dr. Gaur, if I asked you, diagnostic industry, where should we be? What should good look like? I would want you to zoom back from, say, the COVID experience, because COVID has been one unique emergency. So everyone seems to have done because life was at risk, but not necessarily that across healthcare the same behaviors are done. So take a look at what would you want the diagnostic industry to be like from your practice point of view? And then I'll build on it from different stakeholders and say what good looks like for each one of them. You're on mute, sir.
You're asking me the very first question. I think I'll definitely start with I think the first question is, I again go back to I still remember when as a child, we used to go to a doctor. There used to be, writing one test and 10 medicines. But today it's almost like, 10 tests and one medicine, So I think what I'm actually looking for is something, I'll probably say it's something like a more of a balanced prescription of diagnostics that is important. Because, if you have to know, because at the moment you are in the patient in the hospital or somebody wants, what is a diagnostic test should be done, how much they can reveal. That is really, if you look at the hospital, all the 70% information or about the disease or a patient or whatever it is revealed by the diagnostic. But only expenditure is only about 7% probably. That's what I think Narendra also has mentioned somewhere. So I think we need to make sure that and number one, the importance of diagnostic should not be really like sideline. It has to be in the front. Utilize make the optimization of diagnostic testing is the first important point. Make protocol, make ethical prescriptions of diagnostics, and make sure there's no overhype over it. Number two, use the appropriate technology, because there are n number of technologies, but then I think there is a lot of confusion over quality, the validation, protocols, and calibrations. Really, I think that awareness have to come. Some kind of awareness, I think you must see now. NABL started. They have something called an entry-level quality accreditation kind of a thing. I think that was a demand. I think not everybody can afford to have a cap or NABL accreditation, because small labs may not be able to have a space and other things, or some kind of but some mandatory from EQUAS participation, transparency in testing, integration kind of with the IT platform, and ensuring that the right protocols and right practices. I think that's what our diagnostic industry is definitely looking for. And lastly, I think there is a lot of work actually happening into R&D. I'll say that research work. A lot of work is happening, but most of the R&D work is not really comes into the practice. I think where is the gap? Because a lot of good tests are being done inside the labs. A lot of people are doing research work, but for the common man utility, I still have to find something like, okay, somebody got a fever. I think you just mentioned about antimicrobial resistance. Somebody has a fever. He walks up. What test? Can I have a test which can reveal whether I've got a bacterial fever or a viral fever or a fungal fever? That will do the needful. I think this is what diagnostics is definitely capable of going forward, and that's what we really look forward, because a personalized diagnostics, but specific disease specific, very finer diagnostics at the doorstep, whether using digital pathology or using point of care devices or using automated platforms. And of course, lastly, India is always the cost at the affordable cost. I think Bharat mentioned in the opening remark, this is the only industry, probably I'll say, in last 5 years, MRPs have not gone up. Rather, in fact, they are gone down to some extent. So well done, to kudos to diagnostics and all support to our devices and the other providers. But I think it's high time that we appreciate that this is an industry which is actually an industry. It's not like a supportive one of the diagnostic lab people. It's overall a full important industry, and it should now probably be a separate, I think, vertical out somewhere where we all are, efforts recognized, and we can deliver, and we will deliver for that.
Thanks, Dr. Gaur. Probably I'll move to Dr. Satish. Is there anything that Dr. Gaur has not covered that you think, in your vision of what good looks like for the diagnostic industry, where it should be? Can you elaborate?
Yeah, ideally, a very conducive government policy which helps development of localization of industry. This is more important for medical device of late. Currently, 60% of our IVD solutions are imported. This import-centric IVD scenario should be changed, and the pandemic has taught us that lesson. Because when there was a mobility issue, supply chain issues, movement is restricted, then only the localization could help India to have this much of capacity for manufacturing as well as TAT and all. So government should be in favor of localization industry in the policy matter. And again, government should be in favor of convergence of the platforms for digitalization. As I told, as earlier also Rashid told, utilization of the village, the rural area to urban area should be one focus. Because unless we have a convergence of the platforms, we cannot have quality diagnostic solutions to the rural areas. Government has come up with Arogya Setu. Of course, Arogya Setu is a big success, and we know that it's a basis of that for surveillance as well as for capturing the disease data. Again, decision has come by the government that Digital Information Security in the Act has brought by the government of India, but that applicability and it is not promoted in such a way that we can use the digitalization for the whole nation. So my thought is that all segments of healthcare come together. Medical industry also should be part of it, and so that we can reach rural areas of the country. Like this way, we can integrate the rural healthcare units with urban hospitals to reduce duplication of cost and treatment and investigation. Because when you go to a rural area, you have a set of tests, then you come back and come to a town, city, again it is being repeated. So unless you have digitalization between the rural and urban area, it's very, very easier. And application of our AI, artificial intelligence, BAs, then predictive diagnosis, as Dr. Go told, predictive analysis, predictive diagnosis will be a major role in future to predict the second wave, third wave, or what will be the community, what will be the next burden of disease to come. So all patterns of disease, trends and all, we need to have a predictive analysis. We have to work on that. Thank you.
Thanks, Dr. Satish. Narendra, you are, say, tools provider view. When you look at it from that perspective, what does good look like? I'm sure you'll do a 360 view of how a provider will be, a policy will be, and what a technology person can be. So what are your views?
Sure. Thanks, Pawan. To start with, I think when we say what good looks like, there needs to be a framework that we need to have also now in the public sector, where we work around some KPIs. Because as we invest in multiple projects, maybe it is related to TB or it is related to safe blood or cancer or NCDs, whatever area we are investing. We want to make sure that where the government is spending its money, it's also getting the right return on its investment. It's reaching the people are getting the right quality health. And the way I look at, because I've been asked right now to give my view on it, what I would say is there need to be proper KPIs in place. In my viewpoint, there needs to be KPIs like a proper project report. What is the time for that particular project? What is the spending authorized for it? What is the wastage that is happening as part of that particular program that's initiated? So there are multiple areas where we can monitor to see how effective and efficient the program is running or the projects are running. And this is something I don't have the visibility, and I could be absolutely wrong, but this is an area where I feel we can possibly do better in terms of how we are bringing healthcare to the masses and where we are spending. The other area which I would like to highlight is that when we look at it, we still look at it from a cost per test standpoint. And we are very happy when we get the lowest cost test, but we never think about what are the repercussions of bad quality. We never think about, what are the hidden costs which are there, what are the wastages that are there. The moment is the lowest cost, we are happy about it. But that doesn't mean the lowest cost would be the lowest cost for the program. And that's where I guess a mindset shift is also required in terms of value-based procurement. That when you're procuring something, are you taking all the different costs into account, and are you looking at it from a total cost standpoint rather than just a cost per test standpoint? When we talk about access, I think there is a lot of work that's happening from an access standpoint. And even at Roche Diagnostics, we're very proud about it, because when we look at 5 years back, we were present in less than 200 cities. Today, we have actually opened up to 440 cities. So we've been able to go and penetrate. And that's also been like our commitment in the country, right? Because we invest with our infrastructure wherever the labs are set up. We invest with our infrastructure over there, and that means that we are also one of the enabling factors in terms of bringing healthcare now and good quality diagnostics to 440 cities in India, and keeping on expanding that, right? Keeping on pushing those borders over there as well. By this, what we are doing is, it's not like just in the name of access. Only the cities have good quality testing, but with our philosophy, we want the access to really go to the tier 2, tier 3, tier 4 cities, We want people to be benefited there with good quality, tests, more accurate results, and this is where we also need the government support as well, because from a spending standpoint, we need that the infrastructure over there is built so that the basic tests which are there are done there. And I know that's the mindset. Even when I hear the health minister, he really wants to make the primary healthcare center stronger, but it will also depend on the whole implementation of things. How do we really go about implementing it? The other thing which I would want to highlight, and it's something very important for me as well, is from a safe blood standpoint, because still in India we are just at 10% guaranteed safe blood, whereas most of even the other emerging countries have moved to 100% safe blood. And this is an area in terms of NAT testing and ensuring that, from a TTI standpoint, people who are donating blood do not get infected, and infected blood is not further passed on. I think it's an important focus area which the government also needs to look at. So I think blood for me, and the reason I bring it up is because blood for me is an essential. It's really an essential thing, and it should be a priority. So when what good looks like, there needs to be very strong regulation that should come in the blood banking segment. There should be strong regulation come that every blood should be a guaranteed safe blood that is that is given to people. And to say we've done really well in a lot of different projects, and that's where, Pawan, to your point, health is a matter of state and district, and we've seen that it really depends on individual people in those states and districts, and they've done some fantastic work. Like the state of Odisha, they have moved completely towards safe blood. It's one state over there that has done that. So the state of MP has also moved towards safe blood. So there are examples that, when you want to do it, you're able to do it. Another project which I can talk of is the NACO HIV, PPP project that was floated, right? The public-private partnership. It's a fantastic, really well executed project by the central government, and I think it's one of the most successful projects that are there as well. And over here also, they have been able to go to one of the remotest pin codes. So let's not also forget that logistics also has gone through a major overhaul in terms of innovation. So when you talk about access through the HIV program, we have been able to demonstrate that we are able to go to the most rural areas and able to collect samples from there as well. So that doesn't stop us from doing that for any other areas if we tap upon the innovation that logistics is bringing on. And finally, India being a very complex, large, diverse country, no one model will fit in, right? So it cannot be a total decentralized model or a total centralized model. It will really have to be looked at that, where the high burden areas are there, you put in the high throughput instruments, where a lot of testing can be done. And then in the lower burden areas, more remote areas, you can move more towards the point of care infrastructure. For specialized testing, again, leverage the power that logistics today is providing, because we are not where 5 years back we were. We moved where we can, through logistics, also provide access to the last mile. And this is what I would really encourage, the government and all of us to look at how we expand that healthcare going forward. So that's from my end, Pawan. I can go on talking. It's a very, very important topic, but I'm just being conscious of time. Thank you.
Thanks, Narendra. I'm definitely picking up threads around logistics, regulation, need for appropriate technology as components of that. What good looks like. It's almost like creating a picture from the various dots that keep emerging. Bharat, let's get to you and hear what good looks like for you from, say, like Dr. Gaur, you also manage labs. You are the conduit between the treatment decision a doctor makes and the technology providers that are available. So what are your views on what should good look like?
Thanks, Pawan. Let me try and take a stab at it this way. Like Dr. Gaur mentioned, pre-COVID or before COVID BC, healthcare was not even discussed. Today, we are moving to discussing it as a fundamental right. Right, Supreme Court has edged towards calling healthcare as a fundamental right and states' responsibility to provide universal health coverage. They haven't gone to the full territory yet, but at least the envelope is being pushed. Now, if you look at it like a fundamental right, what really it sets up is a stage for a universal health coverage or solving this problem at a population scale. I had a chance to hear Nandan Nilekani once, and he talked about his experience with Aadhaar. And he talked about trying to solve problems at population scale is very different from trying to solve population or problems at a smaller level, because all the issues of geopolitical dynamics, everything comes into picture. So really what we must look at as a country is to solve this at a population scale. Now, there are 3 or 4 building blocks as I see. One is, if we have to deliver solutions at population scale, only way we can do that is to reach it digitally. Now, I'm very happy that the government has taken the initiative on NDHM. It is a starting point, will evolve over a period of time, but there is a digital UPI-like exchange which will come into picture. So that is one of the good things that the government is doing, and we must all participate in helping co-create this NDHM agenda, which will bring in information exchange at a standardized format level. It'll have multiple implications of test code standardization, region code standardization, quality standardization. The whole works will get standardized because the patient report has to be standardized. The second building block, as I would call it, is the doctor capacity building. Right. Ultimately, there has to be a medical expert who is able to opine on a certain report. Either machines will do it through auto validation, or you use AI technologies, or there will be a supra layer of a doctor who will have to train medical professional who look at it. Now, if you look at India as a country, there are many, many districts where you don't find pathologists. Right? Let's take Mao in UP, or Gonda, or some of this far-rung, Jahanabad in Bihar. Very difficult to find trained people because doctors who are trained would like to stay in the city. Now, how do you still provide a quality care in all these smaller districts of India, which are far away from urban centers? Because those people also, have the fundamental right to quality health care. That can happen only when you change the regulatory framework, possibly of encouraging remote reporting. Right, so you collect the sample in place, you conduct a test under supervision using technology to be able to do it. It's only just now that we have got approvals from the regulatory body for even teleconsultation. Till COVID came in, every patient was supposed to be seen physically by a doctor. So we are making progress on that count, but if you're able to accelerate the pace of adoption of new regulations, digital reporting, remote reporting, AI-based reporting. So some of those initiatives also will have to come into play for a good picture of healthcare to emerge in India, and which is really solving problem of healthcare at a population scale.
And thanks, Bharat. Probably I'll get Rajgopal to say, hey, I know that insurance probably wouldn't even want to play in that diagnostics, OPD and all, but what would you think is a good looks like for the diagnostic industry to be essential to healthcare? And then how does a payer look at it?
Contrary to Billy, actually, we would love to have it as part of coverage. Let me explain. So insurance, there are 2 ways we're going to grow. One is getting more people to insure, so government to Ayushman or to private initiatives. A significant number of people are insured today. Forget the 3% numbers being quoted. That's not true, because government schemes, CGHS, ECHS put together, a significant percentage of people actually is insured today. Let's say 80, 90 crores as some form of coverage. Is it adequate? Generally, no. Generally, some schemes cover very limited part of the whole healthcare spend. So getting more people is going to get more difficult as we go forward. So the only way for us to expand is to make the coverage more comprehensive. And diagnostics will play a key role. So I would be excited if diagnostics become, and pharmacy, OPD becomes part of health insurance. that is bound to happen. Either we participate or get left out. The second part of what good looks like, Bharat has mentioned regarding NDHM and digitization, and some other speakers also said it. That's the most important, tool for us, or the backbone for us to include it. The other day I was saying to you, saying that to process an OPD claim costs more money today than actually the invoice. If I get a 150 rupee invoice for X-ray, I spend more money processing it than that 150 rupees. So the sheer logistics of processing this do not work out. So digitization, electronic receipts, invoicing, payment, that backbone as envisaged in NDHM, HL7 standards, that is, that's one of the backbones for coverage to expand on the technology side. Second, on the clinical side, again, coming back to treatment protocols. Today, if some test is done, is it required to be done? How do we monitor, measure, even question that? So when we are in doubt of something, we generally tend to exclude. That's the insurance way of doing things. You don't understand, you exclude it. That solves the problem for us. But we need to get our hands dirty, probably work with the diagnostic centers, hospitals. In fact, we did work with STPs for a few medical conditions, surgical conditions which were surgeries rather. Probably we need to get into more detailed STPs to work through the standards. With that happening, I think coverage will expand, because the next set of insurance products are looking at OPD, but as I said, we're just on the dipping our feet and not jumping in. So with these initiatives, I see that happening. Just some numbers in terms of urban, rural. In our case, the problem of rural access to diagnostics works a little lopsided. So if you look at diagnostics as part of inpatient claims we pay, I'm talking about medical cases, leave surgical, there the percentage is much smaller. In urban centers, that tends to be, let's say, close to 10% of the invoice we get for diagnostics. And medicine tends to be slightly lower. In a smaller center, diagnostic center, very small percentage, but you tend to see more, as you started, abuse of antibiotics, much wider set of antibiotics being given, because it's trying to carpet bomb a much wider range of conditions because the diagnostic is not available. So, access and care access of diagnostics, protocol driven, these things are not going to make insurance expensive in any way. They'll help the patient. And in the whole thing, we keep joking, saying that we're the only guys who make money if the customer is healthy. Every other healthcare participant makes money out of sickness except us. So anything that avoids, prevents a care, gives better care, so there's no complication, we tend to benefit. So for us to participate in this, it's a matter of, as I said, logistics, protocols, and the backbone required to do it. And I'm sure a decade later, we won't be having this conversation, because, as I said, we would be part of the healthcare delivery. We'll play a part. That's what I wanted to say. On a closing part, some people would have read the numbers. So the insurance industry received close to 24 lakh COVID claims, out of which more than 50% are received this year. So we received, first 4 months, we received more claims than the whole of last year. So just like the healthcare providers rising to the occasion, even insurers rose to the occasion. We got some 30,000 crores worth of claims for the industry. Anyway, I just thought that's an interesting statistic for people to know. So I'm not worried about diagnosis being part of it. It's just that if we agree to the rules, it will make it faster for us to get into it.
Oh, thanks, Rajgopal. And it is very refreshing to hear your view saying that you welcome to be included, because in the end, it will be some gain for the society in terms of the outcomes. So let me close this part of the section out with Rashi. Rashi, what would good look like for you on diagnostic industry's future?
So Pavan, I'm going to share something very personal. I come from a very small town, and you may have heard of Yamunanagar. When I was growing up in Yamunanagar, there were no good medical facilities. There were no good hospitals. And as I grew up, I moved to Delhi. I made my parents move for one single reason: good healthcare facility. That was the only reason I've made the move from Yamunanagar to Delhi. And I'm very passionate about it. And that's why when I talk about point of care, or testing in small cities. That's where it comes from, right? What is the big issue? Why are we not able to give that quality healthcare in these small towns and cities? The two fundamental issues that I saw, at least as a child also, as I was growing up, right? There is no infrastructure. And to build that infrastructure in these places is extremely hard, right? The government is doing its best to do that, to build infrastructure, but it's going to take us years before we are able to reach all these small towns and cities to scale up the infrastructure, the kind of infrastructure we're looking for. And the second is, and somebody spoke about this, right? You don't get any trained manpower over there. Anybody with a little bit of skill, look at me. I left Yamunanagar. I moved out. Right? Anybody with a little bit of skill will see or capability, will see opportunities outside and will want to move out. Basically, what we need, if we are really serious about scaling up diagnostics in these small towns and cities and really taking that testing or any kind of medical facility or healthcare to those small towns and cities, we got to dumb it down. Dumb it down so much that is extremely simple to use. A simple ASHA worker should be able to use a test, do the test for the patient, and move on. There should be no need for the infrastructure because we all know, and I think everybody here would agree, it's going to be extremely hard to set it up, right? So we should be able to get a test or a technology that doesn't require you to set up, say, a biosafety cabinet, for example, right? Because that's the only way we'll be able to scale it up. There should be no loss of follow-up. While the tests will get collected, they will come to a central place, but there is still a lot of time that is lost and before the treatment can be started. And so my ideal, really, I mean, I'm coming from, like I said, from a place where I've not stayed because I thought I've not let my parents stay because there was no good medical facilities. Really good for me would be to get a technology or a test that will help. That's very simple. Like I said, dumb it down. It's very simple to use. It provides a reliable result, which can be replicated no matter where you do the test. You get the same result because you've dumbed it down so much there is no manual intervention. And basis that, then the treatment can be started. To Rajgopalan's point, right? It is not symptomatic based, but it is diagnostic based. If we can get something like that, and we've seen that, the government's done a fantastic job, say, for example, with TB program, right? We've seen that scale up tremendously, and we've seen the success of that program. We were able to dumb down the test. We were able to make it so simple that everybody is able to use the test and then hence drive treatment protocols much faster than what we've seen in any other disease state. I think my ideal would be if we can replicate that for other disease states as well.
Hey, thanks, Rashi. I am watching the clock and I do have Dr. Gaur. Dr. Gaur, close it out. I have a couple of questions.
Yeah,
for
just
the government colleagues.
one. I think when coming out of Rashi and Bharat, what they mentioned, I think I always say that it's time that we have ATMs, we should have a path cafes where you have point of care devices, and there you just walk in, a drop of blood, and then all those are integrated with technology, and there's a centralized remote reporting actually to control the quality. I think that's what diagnostic industry is. I think healthcare industry wants, probably, for that matter. Healthcare people, all the people want. I think, and we are heading for that. Time is not far away. I think it's time that remote reporting, all these point of care devices, they integrated well, controlled by the quality, centrally controlled by the quality. I think that will do the justice to what we are talking about. And lastly, another important is what they mentioned about the sample transport. I think this where Narendra has mentioned. I think it's another area we're looking for is alternate sample. Can we have a testing from body fluids, saliva, urine, and other things? I think that will do wonders because that will sort out a lot of logistic issues of phlebotomy issues. And this is where I think we are all hoping for, and that's how diagnostic industry, they'll do a lot of good to diagnostic industry, when it research, devices, technology, and insurance. Of course, I'm happy to hear that they're going to include us. That will be good sign, and I'm sure they do it fast. But why wait for 5 years?
A facetious comment, probably, Dr. Gaur, on your dream of one drop of blood and integrated testing. Someone did attempt it in the United States, Theranos, and ended up in being a fraud to start
I understand
with.
that,
But
but
I hope
that's where I
the
said.
dream will be realized someday. Let me just go to Suchita and Anup on one aspect. We've focused a lot on, say, what a regulation could be, what technology should be, what logistics should be. What we probably, I want to ask both of you to respond to is what behavior should be. You could have all of this, but if the practitioner is not going to change their philosophy of diagnosis and then testing, it's not going to be a successful vision. So Suchita, let me start with you and then probably Anup. What do you think we should be doing, we as in say government or the stakeholders, in actually making that shift with the practitioners also?
Yeah, thanks, Pawan. It was very nice to listen to all the industry stakeholders here. And before coming to this point, I would also like to express my wish list that about what good should be from government standpoint. I'm not very new to the government system, but what I see, I have huge lot of experience working in the area of medical devices and innovations, steering, helping, giving hand-holding support to startups by way of the Stanford India by Design program of DBT and other medical device initiatives. So what I see, and that's a pain point, when I see that medical devices are produced based on unmet needs, and once they are developed, startups are formed, but there is a gap in the public procurement. Those technologies which have been developed based on unmet needs don't penetrate at volumes, and therefore the access issue still remains. So my good point, what will sound good to me would be that their sector is very diverse. So if we could have, if we do some evaluation along with the industry to identify the priority sectors, because we can't do magic to all the sectors, all the various kind of products which are available in this sector by providing them hand-holding support. In case of COVID, as Dr. Kaur mentioned, we have definitely seen that Make in India really works. I mean, we didn't have any capabilities when we looked at the COVID scenario in India, but within a year's time, I would say 6 to 8 months, all the indigenous capabilities were time tested, and we didn't have to depend upon imports in this sector for one case. So if we can do it for one case, why can't we do it for all the other diseases like TB elimination? We have so many national programs on front. So what we need to do, what would sound good to me, that we evaluate the priorities, what is needed by the industry, and what are they, and match them with the capabilities, what are the indigenous capabilities, and accordingly promote innovation and indigenization in those priority areas. Being at the government, specifically at ICMR, if we can provide end-to-end support to these products and facilitate robust validation, provide guidelines so that they go through regulatory mechanism, and then do operational feasibility studies for those products by deploying them at primary healthcare centers for difficult to reach areas. And once we do those pilots and pilots are successful, we can recommend them for absorption in the national health programs. So that would sound really good to me. End-to-end hand-holding support from what is needed to what should be deployed, and then the accessibility and affordability issues are also taken care by the government by providing the funding support so that things really work. So that's my dream, that if we can provide end-to-end support to the medical device and diagnostics industry, and in that view also our DG is very positive. This sector is very close to us, and therefore we are also planning to start some national level programs in a mission mode, so as to provide support to this sector. So this is something, a wish list was very much there, and therefore we are also working to realize that wish list somewhere, and I'm not sure how much we'll be able to do, but definitely the intentions are quite high, and we are also working in that direction. So that's something good to me. And definitely, as you mentioned, the Make in India products also have an issue of getting absorbed and accepted by the doctors. So that is again an issue we know very well, and therefore lot of we will need to talk to these people, and the change in mindset may take time, but definitely once we start doing that, somewhere we'll reach. So we really need to have the change in mindset for Make in India products, for getting them absorbed at the end. Therefore, I think maybe we will need to speak and raise our voice all together so as to change that mindset. Thank you.
Thanks, Suchita. Anup, I have a question specific for you. we can have as many technologies and at whatever adoption rate. How do you actually change the mindset of the doctors to go first diagnose and then treat, which is the prerequisite for all of what we've said as a vision state? Any thoughts on from your side?
Thank you, Pawan. This is a very important issue, and in fact, in tertiary care centers or in the urban area, it's not a very big deal. Means their doctors are tuned to diagnosing first and treating later on. But then in rural areas, we see instead of going for diagnostics, the people, the general practitioners or even the alternate healthcare providers, they will go for a cocktail of medicines first. And if the patient is not cured, then he will be referred to a higher center. So this practice needs to be changed. Our industry is very much supportive, and we are able to produce affordable and quality diagnostics, and they should be produced for more and more diseases, and they should be done at the point of care level. So this is the first thing from provider side. Second thing, tomorrow I would like to see medical representatives convincing the general practitioners, particularly in the rural areas, because of course government is doing its best, and in the public health setup, more and more diagnostics are being included, and they are also quality tested. And this is the time, taking the cue from the COVID examples, if we have done more than 50 crore COVID tests over the past 18 months. So people are receptive to diagnostics. So this is the time when we will be, we should be starting. So tomorrow I would like to see even the general practitioners or even the alternative healthcare providers going with the kitty of the diagnostics.
Thanks, Dr. Anvikar. I do have a consciousness of next 4 minutes. We have only 4 minutes to wrap this up. So probably a way I could do it is I'd request you all stay with the 30 seconds maximum ceiling. If you were given the magic that Suchita was referring to, I give you a wand, you swipe, one wish is fulfilled. Don't ask me for Rolls Royce. That magic wand, use it for what do you think should be done to get to your good state that you all talked about? You all gave what should be the diagnostics vision that we should have. I give, say, one wish for you that you can fulfill. What would that be? Let's start with probably, I'll just use the screen. Let's start with Narendra.
I think it would be a collaboration with the industry and working together to really come up with the regulations, the priorities, and the roadmap on how do we get there and achieve it.
Got it. Narendra is first one, so he had the handicap of not knowing what that power of that magic was. Feel free to widen it. If you say, I want to be able to do a diagnostic test with one drop of blood, that's okay. What I wanted to understand for our panelists and as well as for our audience is what would actually be your wish to change that? So go, Rajgopal. What would that one wish be?
Again, I'll repeat it. I think digitization and standardization would be the two, not one, but two things I would want. They can happen as quickly as possible. It's optimal care for the patient and good for us.
And thanks, Rajgopal. Dr. Satish, what's that one magic wish?
Yeah. Every person of the country should be linked with a unique ID like Aadhaar card, where we can capture the health status of that person without fail if you go anywhere in India, for which the total digitalization of the healthcare system from top to bottom should happen.
Got it. Bharat?
Make health a fundamental right. It will solve everything.
Thank you. Got it. Rashi?
I'm going to build on what Bharat said, make health a fundamental right by helping with some policy frameworks that can help, technologies that already exist globally also, make with global certifications, WHO recommendations, make them much easier to get them to India and compress that time.
Got it. Dr. Gaur?
I think I'll go definitely with what Bharat and Rashi is saying, fundamental right. But before, one more thing I'd like to add is because it's important to make sure that clinicians are well aware of the practice, especially in Tier 2, and we should send a message to the users, to patients, that clinicians can hear your heartbeat, but the diagnostics know what's beating your heart. I think that's kind of a thing we should be doing.
Thank you. Anup, what would that one wish for you be?
Yeah, diagnostics reaching the last mile.
Suchita?
Regulatory clarity. Software when you just type the device and you get the regulatory strategy clear.
Wonderful. If I were to be able to share my view, one wish is probably I would say government should make up its mind whether healthcare is its subject or it is a free for all. I think that would be my wish because everything else they can solve after that. They have to decide, will I invest in healthcare for my people or will I let it be someone else's responsibility? So I think that would be, thank you so much. I think we've had great discussion. I want to respect everyone's time, your valuable time. We do have a back office which will probably synthesize some of these thoughts around need for access, need for probably technology appropriate for India that can be taken to the last mile, quality across all levels where we do, some basic regulatory framework that can help determine diagnostics can be expanded, and a fundamental change in practitioners' mindset in terms of using diagnosis to help treatment as opposed to symptoms helping treatment. Thank you so much for your time and look forward to building on this as we meet further. Thank you. Over to you, Swati.
Thank you.
Bye.
Thank you, Pawan.
Thank you.
Thank
Thank
you.
you. Bye.
Thank you.
Thank you, everybody.
Thank you, Mr. Mostrella, and thank you all the eminent panelists. Do join us for the next plenary session, which is about to begin in 15 minutes at 11:30. Thank you so much, sir. Thank you.
Thank you.
Thank you.
Bye-bye.
Thank
Bye.
you.
Thanks.
focused to in-depth R&D for making highly specialized systems. We are proud to say that today, Polymed is one of the leading manufacturers of infusion products in the world, exporting to an array of over 110 countries. We are Polymed, and we care for you. Our drive comes from our compassion for saving lives and building a healthier society, a happier society. Polymed. We care as we cure.
Thermopenpol Private Limited is the market leader in India in the field of equipment and disposables for the blood transfusion industry. Established in 1985, it pioneered the manufacturing of disposable blood bags in India. Headquartered in Trivandrum, the company employs a workforce of around 1,400 people. Blood Bag Factory makes wide range of blood bags under the whole blood platform. BBF has a capacity to produce 10 million sets of blood bags per annum. The process starts with extruding PVC pellets and tube, flowing through bag sealing to form individual bags. The bags are completed to get the configurations of single, double, triple, quadruple and penta bags using a combination of tube bag assembly stage. The pharmaceutical solutions are filled into respective final configuration of bag. These filled go into primary packing to reach steam sterilization chambers for their terminal sterilization. Secondary packing follows after final inspection and then into required cartons for shipping. The vision of TBCT EMC was to form a team based in India to align with the high-level company strategy to expand innovation to fulfill 24-hour clock functioning. I&D India in its operations have delivered excellent results for the investment made on the facility and resources. The team is in close collaboration with the global associates. The premises is having facilities such as laboratory space and aging chambers, office space for I&D disposables, design quality and regulatory affairs meeting rooms, laboratory and training halls. Medical Equipment Division assembles close to 21 different varieties of products used in the whole blood collection process, starting with blood mixers, RF sealers, donation couches, component separators, component storage refrigerators, freezers, agitators, special purpose scales, water baths for issue of plasma, etc. Close to 4,000 units are produced every year. Sub-assemblies made as per in-house specifications at various subcontractors are assembled and tested 100% before final clearance to customers. We believe in developing good customer relationships. Thermopenpol products are used in blood centers across 75 countries globally. We champion the cause of promoting voluntary blood donation along with other CSR activities. Thermopenpol continues in its quest of unlocking the potential of blood and providing better patient outcomes.
On-demand glucose monitoring that doesn't interrupt life because you're always on. Another life-changing technology from Abbott. So you don't wait for life, you live it.
What is care all about? An endearing smile, a soothing touch, or perhaps the comforting reassurance of an honest commitment? At Polymed, for years, our commitment to provide the highest quality healthcare to mankind has run deeply through all aspects of our ideology, decisions, and work. Care, concern, and love for humanity. Polymed was established in 1995 and started manufacturing operations in 1997 with a vision of providing the highest quality of healthcare to mankind. Since inception, Polymed has been on an ever-expanding journey of achievements, marking key milestones year after year. Our values of integrity, care, ownership, learning and inclusivity puts us in a dominant position in the healthcare industry. Polymed as a brand is committed to continually evolve and innovate products that are proven, safe and sustainable. Our innovations are focused not only on creating value today, but also to prepare healthcare for a better tomorrow. Our varied specialities include infusion therapy, vascular access, dialysis, respiratory care, urology, blood management, oncology, gastroenterology, blood collection system, surgery and wound management, and anesthesia. While our technologies are truly state-of-the-art, our business model is state-of-the-heart.
Polymed is now moving towards its new orbit of bringing more products which are close to clinicians, healthcare practitioners.
Our acquisition of Plan One Health, a leading Italian medical devices company, has further allowed us to expand our horizons, adding focus to in-depth R&D for making highly specialized systems. We are proud to say that today, Polymed is one of the leading manufacturers of infusion products in the world, exporting to an array of over 110 countries. We are Polymed, and we care for you. Our drive comes from our compassion for saving lives and building a healthier society, a happier society. Polymed. We care as we cure.
Thermopenpol Private Limited is the market leader in India in the field of equipment and disposables for the blood transfusion industry. Established in 1985, it pioneered the manufacturing of disposable blood bags in India. Headquartered in Trivandrum, the company employs a workforce of around 1,400 people. Blood Bag Factory makes wide range of blood bags under the whole blood platform. BBF has a capacity to produce 10 million sets of blood bags per annum. The process starts with extruding PVC pellets and tube, flowing through bag sealing to form individual bags. The bags are completed to get the configurations of single, double, triple, quadruple and penta bags using a combination of tube bag assembly stage. The pharmaceutical solutions are filled into respective final configuration of bag. These filled go into primary packing to reach steam sterilization chambers for their terminal sterilization. Secondary packing follows after final inspection and then into required cartons for shipping. The vision of TBCT EMC was to form a team based in India to align with the high-level company strategy to expand innovation to fulfill 24-hour clock functioning. I&D India in its operations have delivered excellent results for the investment made on the facility and resources. The team is in close collaboration with the global associates. The premises is having facilities such as laboratory space and aging chambers, office space for I&D disposables, design quality and regulatory affairs meeting rooms, laboratory and training halls. Medical Equipment Division assembles close to 21 different varieties of products used in the whole blood collection process, starting with blood mixers, RF sealers, donation couches, component separators, component storage refrigerators, freezers agitators, special purpose scales, water baths for issue of plasma, etc. Close to 4,000 units are produced every year. Sub-assemblies made as per in-house specifications at various subcontractors are assembled and tested 100% before final clearance to customers. We believe in developing good customer relationships. Thermopentol products are used in blood centers across 75 countries globally. We champion the cause of promoting voluntary blood donation along with other CSR activities. Thermopentol continues in its quest of unlocking the potential of blood and providing better patient outcomes.
On-demand glucose monitoring that doesn't interrupt life because you're always on. Another life-changing technology from Abbott. So you don't wait for life, you live it.
What is care all about? An endearing smile, a soothing touch, or perhaps the comforting reassurance of an honest commitment? At Polymed, for years, our commitment to provide the highest quality healthcare to mankind has run deeply through all aspects of our ideology, decisions, and work. Care, concern, and love for humanity. Polymed was established in 1995 and started manufacturing operations in 1997 with a vision of providing the highest quality of healthcare to mankind. Since inception, Polymed has been on an ever-expanding journey of achievements, marking key milestones year after year. Our values of integrity, care, ownership, learning, and inclusivity puts us in a dominant position in the healthcare industry. Polymed as a brand is committed to continually evolve and innovate products that are proven, safe and sustainable. Our innovations are focused not only on creating value today, but also to prepare healthcare for a better tomorrow. Our varied specialities include infusion therapy, vascular access, dialysis, respiratory care, urology, blood management, oncology, gastroenterology, blood collection system, surgery and wound management, and anesthesia. While our technologies are truly state-of-the-art, our business model is state-of-the-heart.
Polymed is now moving towards its new orbit of bringing more products which are close to clinicians, healthcare practitioners.
Our acquisition of Plan One Health, a leading Italian medical devices company, has further allowed us to expand our horizons, adding focus to in-depth R&D for making highly specialized systems. We are proud to say that today, Polymed is one of the leading manufacturers of infusion products in the world. exporting to an array of over 110 countries. We are Polymed, and we care for you. Our drive comes from our compassion for saving lives and building a healthier society, a happier society. Polymed. We care as we cure.
Thermopenpol Private Limited is the market leader in India in the field of equipment and disposables for the blood transfusion industry. Established in 1985, it pioneered the manufacturing of disposable blood bags in India. Headquartered in Trivandrum, the company employs a workforce of around 1,400 people. Blood Bag Factory makes wide range of blood bags under the whole blood platform. BBF has a capacity to produce 10 million sets of blood bags per annum. The process starts with extruding PVC pellets and tube, flowing through bag sealing to form individual bags. The bags are completed to get the configurations of single, double, triple, quadruple and penta bags using a combination of tube bag assembly stage. The pharmaceutical solutions are filled into respective final configuration of bag. These filled go into primary packing to reach steam sterilization chambers for their terminal sterilization. Secondary packing follows after final inspection and then into required cartons for shipping. The vision of TBCT EMC was to form a team based in India to align with the high-level company strategy to expand innovation to fulfill 24-hour clock functioning. I&D India in its operations have delivered excellent results for the investment made on the facility and resources. The team is in close collaboration with the global associates. The premises is having facilities such as laboratory space and aging chambers, office space for I&D disposables, design quality and regulatory affairs meeting rooms, laboratory and training halls. Medical Equipment Division assembles close to 21 different varieties of products used in the whole blood collection process, starting with blood mixers, RF sealers, donation couches, component separators, component storage refrigerators, freezers, agitators, special purpose scales, water baths for issue of plasma, etc. Close to 4,000 units are produced every year. Sub-assemblies made as per in-house specifications at various subcontractors are assembled and tested 100% before final clearance to customers. We believe in developing good customer relationships. Thermopenpol products are used in blood centers across 75 countries globally. We champion the cause of promoting voluntary blood donation along with other CSR activities. Thermopenpol continues in its quest of unlocking the potential of blood and providing better patient outcomes.
On-demand glucose monitoring that doesn't interrupt life because you're always on. Another life-changing technology from Abbott. So you don't wait for life, you live it.
What is care all about? An endearing smile, a soothing touch, or perhaps the comforting reassurance of an honest commitment? At Polymed, for years, our commitment to provide the highest quality healthcare to mankind has run deeply through all aspects of our ideology, decisions, and work. Care, concern, and love for humanity. Polymed was established in 1995 and started manufacturing operations in 1997 with a vision of providing the highest quality of healthcare to mankind. Since inception, Polymed has been on an ever-expanding journey of achievements, marking key milestones year after year. Our values of integrity, care, ownership, learning and inclusivity puts us in a dominant position in the healthcare industry. Polymed as a brand is committed to continually evolve and innovate products that are proven, safe and sustainable. Our innovations are focused not only on creating value today, but also to prepare healthcare for a better tomorrow. Our varied specialities include infusion therapy, vascular access, dialysis, respiratory care, urology, blood management, oncology, gastroenterology, blood collection system, surgery and wound management, and anesthesia. While our technologies are truly state-of-the-art, our business model is state-of-the-heart.
Polymed is now moving towards its new orbit of bringing more products which are close to clinicians, healthcare practitioners.
Our acquisition of Plan One Health, a leading Italian medical devices company, has further allowed us to expand our horizons, adding focus to in-depth R&D for making highly specialized systems. We are proud to say that today, Polymed is one of the leading manufacturers of infusion products in the world, exporting to an array of over 110 countries. We are Polymed, and we care for you. Our drive comes from our compassion for saving lives and building a healthier society, a happier society. Polymed. We care as we cure.
Penpal Private Limited is the market leader in India in the field of equipment and disposables for the blood transfusion industry. Established in 1985, it pioneered the manufacturing of disposable blood bags in India. Headquartered in Trivandrum, the company employs a workforce of around 1,400 people. Blood Bag Factory makes wide range of blood bags under the whole blood platform. BBF has a capacity to produce 10 million sets of blood bags per annum. The process starts with extruding PVC pellets and tube, flowing through bag sealing to form individual bags. The bags are completed to get the configurations of single, double, triple, quadruple and penta bags using a combination of tube bag assembly stage. The pharmaceutical solutions are filled into respective final configuration of bag. These filled go into primary packing to reach steam sterilization chambers for their terminal sterilization. Secondary packing follows after final inspection and then into required cartons for shipping. The vision of TBCT EMC was to form a team based in India to align with the high-level company strategy to expand innovation to fulfill 24-hour clock functioning. I&D India in its operations have delivered excellent results for the investment made on the facility and resources. The team is in close collaboration with the global associates. The premises is having facilities such as laboratory space and aging chambers, office space for I&D disposables, design quality and regulatory affairs meeting rooms, laboratory and training halls. Medical Equipment Division assembles close to 21 different varieties of products used in the whole blood collection process, starting with blood mixers, RF sealers, donation couches, component separators, component storage refrigerators, freezers, agitators, special purpose scales, water baths for issue of plasma, etc. Close to 4,000 units are produced every year. Sub-assemblies made as per in-house specifications at various subcontractors are assembled and tested 100% before final clearance to customers. We believe in developing good customer relationships. Thermopenpol products are used in blood centers across 75 countries globally. We champion the cause of promoting voluntary blood donation along with other CSR activities. Thermopenpol continues in its quest of unlocking the potential of blood and providing better patient outcomes.
On-demand glucose monitoring that doesn't interrupt life because you're always on. Another life-changing technology from Abbott. So you don't wait for life, you live it.
What is care all about? An endearing smile, a soothing touch, or perhaps the comforting reassurance of an honest commitment? At PolyMed, for years, our commitment to provide the highest quality healthcare to mankind has run deeply through all aspects of our ideology, decisions, and work. Care, concern, and love for humanity. PolyMed was established in 1995 and started manufacturing operations in 1997 with a vision of providing the highest quality of healthcare to mankind. Since inception, PolyMed has been on an ever-expanding journey of achievements, marking key milestones year after year. Our values of integrity, care, ownership, learning, and inclusivity puts us in a dominant position in the healthcare industry. PolyMed as a brand is committed to continually evolve and innovate products that are proven, safe and sustainable. Our innovations are focused not only on creating value today, but also to prepare healthcare for a better tomorrow. Our varied specialities include infusion therapy, vascular access, dialysis, respiratory care, urology, blood management, oncology, gastroenterology, blood collection system, surgery and wound management, and anesthesia. While our technologies are truly state-of-the-art, our business model is state-of-the-heart.
PolyMed is now moving towards its new orbit of bringing more products which are close to clinicians, healthcare practitioners.
Our acquisition of Plan One Health, a leading Italian medical devices company, has further allowed us to expand our horizons, adding focus to in-depth R&D for making highly specialized systems. We are proud to say that today, PolyMed is one of the leading manufacturers of infusion products in the world. exporting to an array of over 110 countries. We are Polymed, and we care for you. Our drive comes from our compassion for saving lives and building a healthier society, a happier society. Polymed. We care as we cure.
Thermopenpol Private Limited is the market leader in India in the field of equipment and disposables for the blood transfusion industry. Established in 1985, it pioneered the manufacturing of disposable blood bags in India. Headquartered in Trivandrum, the company employs a workforce of around 1,400 people. Blood Bag Factory makes wide range of blood bags under the whole blood platform. BBF has a capacity to produce 10 million sets of blood bags per annum. The process starts with extruding PVC pellets and tube, flowing through bag sealing to form individual bags. The bags are completed to get the configurations of single, double, triple, quadruple and penta bags using a combination of tube bag assembly stage. The pharmaceutical solutions are filled into respective final configuration of bag. These filled go into primary packing to reach steam sterilization chambers for their terminal sterilization. Secondary packing follows after final inspection and then into required cartons for shipping. The vision of TBCT EMC was to form a team based in India to align with the high-level company strategy to expand innovation to fulfill 24-hour clock functioning. I&D India in its operations have delivered excellent results for the investment made on the facility and resources. The team is in close collaboration with the global associates. The premises is having facilities such as laboratory space and aging chambers, office space for I&D disposables, design quality and regulatory affairs meeting rooms, laboratory and training halls. Medical Equipment Division assembles close to 21 different varieties of products used in the whole blood collection process, starting with blood mixers, RF sealers, donation couches, component separators, component storage refrigerators, freezers, agitators, special purpose scales, water baths for issue of plasma, etc. Close to 4,000 units are produced every year. Sub-assemblies made as per in-house specifications at various subcontractors are assembled and tested 100% before final clearance to customers. We believe in developing good customer relationships. Thermopenpol products are used in blood centers across 75 countries globally. We champion the cause of promoting voluntary blood donation along with other CSR activities. Thermopenpol continues in its quest of unlocking the potential of blood and providing better patient outcomes.
On-demand glucose monitoring that doesn't interrupt life because you're always on. Another life-changing technology from Abbott. So you don't wait for life, you live it.
What is care all about? An endearing smile, a soothing touch, or perhaps the comforting reassurance of an honest commitment? At Polymed, for years, our commitment to provide the highest quality healthcare to mankind has run deeply through all aspects of our ideology, decisions, and work. Care, concern, and love for humanity. Polymed was established in 1995 and started manufacturing operations in 1997 with a vision of providing the highest quality of healthcare to mankind. Since inception, Polymed has been on an ever-expanding journey of achievements, marking key milestones year after year. Our values of integrity, care, ownership, learning and inclusivity puts us in a dominant position in the healthcare industry. Polymed as a brand is committed to continually evolve and innovate products that are proven, safe and sustainable. Our innovations are focused not only on creating value today, but also to prepare healthcare for a better tomorrow. Our varied specialities include infusion therapy, vascular access, dialysis, respiratory care, urology, blood management, oncology, gastroenterology, blood collection system, surgery and wound management, and anesthesia. While our technologies are truly state-of-the-art, our business model is state-of-the-heart.
Polymed is now moving towards its new orbit of bringing more products which are close to clinicians, healthcare practitioners.
Our acquisition of Plan One Health, a leading Italian medical devices company, has further allowed us to expand our horizons, adding focus to in-depth R&D for making highly specialized systems. We are proud to say that today, Polymed is one of the leading manufacturers of infusion products in the world, exporting to an array of over 110 countries. We are Polymed, and we care for you. Our drive comes from our compassion for saving lives and building a healthier society, a happier society. Polymed. We care as we cure.
Termopenpol Private Limited is the market leader in India in the field of equipment and disposables for the blood transfusion industry. Established in 1985, it pioneered the manufacturing of disposable blood bags in India. Headquartered in Trivandrum, the company employs a workforce of around 1,400 people. Blood Bag Factory makes wide range of blood bags under the whole blood platform. BBF has a capacity to produce 10 million sets of blood bags per annum. The process starts with extruding PVC pellets and tube, flowing through bag sealing to form individual bags. The bags are completed to get the configurations of single, double, triple, quadruple and penta bags using a combination of tube bag assembly stage. The pharmaceutical solutions are filled into respective final configuration of bag. These filled go into primary packing to reach steam sterilization chambers for their terminal sterilization. Secondary packing follows after final inspection and then into required cartons for shipping. The vision of TBCT EMC was to form a team based in India to align with the high-level company strategy to expand innovation to fulfill 24-hour clock functioning. I&D India in its operations have delivered excellent results for the investment made on the facility and resources. The team is in close collaboration with the global associates. The premises is having facilities such as laboratory space and aging chambers, office space for I&D disposables, design quality and regulatory affairs meeting rooms, laboratory and training halls. Medical Equipment Division assembles close to 21 different varieties of products used in the whole blood collection process, starting with blood mixers, RF sealers, donation couches, component separators, component storage refrigerators, freezers, agitators, special purpose scales, water baths for issue of plasma, etc. Close to 4,000 units are produced every year. Sub-assemblies made as per in-house specifications at various subcontractors are assembled and tested 100% before final clearance to customers. We believe in developing good customer relationships. Thermopenpol products are used in blood centers across 75 countries globally. We champion the cause of promoting voluntary blood donation along with other CSR activities. Thermopenpol continues in its quest of unlocking the potential of blood and providing better patient outcomes.
On-demand glucose monitoring that doesn't interrupt life because you're always on. Another life-changing technology from Abbott. So you don't wait for life, you live it.
What is care all about? An endearing smile, a soothing touch, or perhaps the comforting reassurance of an honest commitment? At Polymed, for years, our commitment to provide the highest quality healthcare to mankind has run deeply through all aspects of our ideology, decisions, and work. Care, concern, and love for humanity. Polymed was established in 1995 and started manufacturing operations in 1997 with a vision of providing the highest quality of healthcare to mankind. Since inception, Polymed has been on an ever-expanding journey of achievements, marking key milestones year after year. Our values of integrity, care, ownership, learning and inclusivity puts us in a dominant position in the healthcare industry. Polymed as a brand is committed to continually evolve and innovate products that are proven, safe and sustainable. Our innovations are focused not only on creating value today, but also to prepare healthcare for a better tomorrow. Our varied specialities include infusion therapy, vascular access, dialysis, respiratory care, urology, blood management, oncology, gastroenterology, blood collection system, surgery and wound management, and anesthesia. While our technologies are truly state-of-the-art, our business model is state-of-the-heart.
Polymed is now moving towards its new orbit of bringing more products which are close to clinicians, healthcare practitioners.
Our acquisition of Plan One Health, a leading Italian medical devices company, has further allowed us to expand our horizons, adding focus to in-depth R&D for making highly specialized systems. We are proud to say that today, Polymed is one of the leading manufacturers of infusion products in the world. exporting to an array of over 110 countries. We are Polymed, and we care for you. Our drive comes from our compassion for saving lives and building a healthier society, a happier society. Polymed. We care as we cure.
Thermopenpol Private Limited is the market leader in India in the field of equipment and disposables for the blood transfusion industry. Established in 1985, it pioneered the manufacturing of disposable blood bags in India. Headquartered in Trivandrum, the company employs a workforce of around 1,400 people. Blood Bag Factory makes wide range of blood bags under the whole blood platform. BBF has a capacity to produce 10 million sets of blood bags per annum. The process starts with extruding PVC pellets and tube, flowing through bag sealing to form individual bags. The bags are completed to get the configurations of single, double, triple, quadruple and penta bags using a combination of tube bag assembly stage. The pharmaceutical solutions are filled into respective final configuration of bag. These filled go into primary packing to reach steam sterilization chambers for their terminal sterilization. Secondary packing follows after final inspection and then into required cartons for shipping. The vision of TBCT EMC was to form a team based in India to align with the high-level company strategy to expand innovation to fulfill 24-hour clock functioning. I&D India in its operations have delivered excellent results for the investment made on the facility and resources. The team is in close collaboration with the global associates. The premises is having facilities such as laboratory space and aging chambers, office space for I&D disposables, design quality and regulatory affairs meeting rooms, laboratory and training halls. Medical Equipment Division assembles close to 21 different varieties of products used in the whole blood collection process, starting with blood mixers, RF sealers, donation couches, component separators, component storage refrigerators, freezers, agitators, special purpose scales, water baths for issue of plasma, etc. Close to 4,000 units are produced every year. Sub-assemblies made as per in-house specifications at various subcontractors are assembled and tested 100% before final clearance to customers. We believe in developing good customer relationships. Thermopenpol products are used in blood centers across 75 countries globally. We champion the cause of promoting voluntary blood donation along with other CSR activities. Thermopenpol continues in its quest of unlocking the potential of blood and providing better patient outcomes.
On-demand glucose monitoring that doesn't interrupt life because you're always on. Another life-changing technology from Abbott. So you don't wait for life, you live it.
What is care all about? An endearing smile, a soothing touch, or perhaps the comforting reassurance of an honest commitment? At Polymed, for years, our commitment to provide the highest quality healthcare to mankind has run deeply through all aspects of our ideology, decisions, and work. Care, concern, and love for humanity. Polymed was established in 1995 and started manufacturing operations in 1997 with a vision of providing the highest quality of healthcare to mankind. Since inception, Polymed has been on an ever-expanding journey of achievements, marking key milestones year after year. Our values of integrity, care, ownership, learning, and inclusivity puts us in a
Hi, Rajiv.
Hi, Elizabeth.
So, did you see the die?
No, I just thought I'll connect myself and see because Ganesh is also going to do that, na?
Just hold on. I'll just call the rest of the speakers.
Yeah, no worries, no worries. I'm just logging off because I'm also वो वैभव का भी session को देख रहा था ना.
Nay, you be on the line, you can mute and then you can be in the panel, listen to the conversation, no problem. You can be in the panel and listen, no problem.
Okay.
Just have to switch off the video, that's all.
I'll mute and switch off the video.
Yes, yes, okay.
Hi, this is Prashant here.
Hi, Prashant.
Hi, Elizabeth.
Hi. Oh, okay.
I just wanted to check if I'm in the right.
Yeah. Manoj is also joined. The rest of the speakers will join just.
Sure, no problem.
Hey, Jay.
Hi, Manoj. Thanks. I'll just call the rest of the speakers, Manoj. Prashant is joined.
Hey, Prashant.
Hey, Manoj. Hi, how are you?
I'm good, man. How are you?
I'm good.
Good to see you. You're in
Mumbai.
Delhi? Mumbai, okay. Hello, Dr. Chivar. Prashant, you able to see me okay?
I would prefer the curtain going back. So, because right now I still see a little bit of a haze on your face. So, if you can draw the curtains, that will actually make sure that it'll light up a little better.
So, Manoj, just want to tell you, I have requested Vibhav and Dr. Rajiv also to be with you just for a support in case if there is anything that you need to have some help or something. So that's the reason I requested Vibhav also to be in the panel itself. He will not be a speaker, but for anything we can always ask them.
Thanks, CJ. I think Vibhav was just finishing with a parallel session as well, right? So I guess he's occupied till 2:30.
Yes. And Rajiv Shibbar is from SMT with Ganesh Sabat's office.
Nice to meet you, Dr. Chivar. So would Mr. Ganesh Sabat be joining in or?
Yes.
He's confirmed, right?
Rajiv, you can speak.
Sorry. Yeah, I just called Ganesh. He was having some issues joining that link. I've just resent a link to him again.
Okay, perfect. But he's confirmed, right?
Yeah. He's confirmed. He's just joining the link. I've just resent the link to him once again.
I didn't get a chance to connect with him prior to this, Rajiv. So, like, probably, for Mr. Sabat, the question can be around the recent spate of policies that the GOI has introduced and how it can propel, local grown companies and, realize the vision of Atmanirbharta. So I'll leave it pretty open-ended and vague so he can comment on that if that's okay.
Sure. I think it won't be a problem. I mean, we discussed this at length yesterday evening also.
Okay.
Had our colleagues on a joint call. So I think it won't be a problem. Yeah.
Sure. Perfect. Thanks. And
Shanti,
Prashant,
how
I'll
are you?
probably ask you on the therapies, introduction of therapies and products and how it can, why evidence is important while considering those, Prashant. So
Sure.
Okay, sounds good.
I got Shishir. I got a question for Shishir as well, and the rest of them will go there. How is Mumbai? Raining?
We had actually a little bit of a dry spell, and then we are back to a little bit of rain. It's pretty characteristic with the Janmashtami, and then it'll continue on a little more till the end of this week, and then Ganpati, and that's it. So I heard Mumbai and Gurgaon is underwater. Oh, sorry, Delhi and Gurgaon is underwater.
Yeah. I've been struggling to come to office almost for the last 3 days.
I'm getting into Delhi tomorrow. I'm in Calcutta actually today. So yeah.
Today it's not raining, so fortunately, the waters receded well. But last 3 days was like a roller coaster on the roads only.
Manoj, Arpit Bajpayee from GEM is joined.
Hello, Mr. Arpit.
Hello, Manojji.
Thanks, and thanks for joining in. And I guess we have still 7 minutes left before the session. So I thought, for you, the question can be around how do you kind of look at data in the complex medical devices industry, and what kind of data do you look at while making policies, bidding policies on GEM, and to make it more user friendly and more scalable. So something around those lines. Does that work for you?
Yeah, surely. So whatever initiative we have taken related to COVID or the MedTech industry, so just have maybe a brief or a detailed discussion on that. Yeah.
Sure. Perfect.
Yeah, I think Ganesh sir has joined also.
Hello, Mr. Sabath. How are you?
Hello, Mr. Madhavan. Doing well. How about you?
Very good. Very good. I'm not sure if you met in any of the earlier forums before.
Probably not.
That's all right. So quick introduction. I take care of Boston Scientific for India and South Asia. I'm pleased to have you.
Pleasure meeting you.
Pleasure to meet you too. So Mr. Ganesh, the question for you, I thought can be around the recent policies that the government of India has introduced, and how probably evidence-based policy making around that can help propel the domestic industry even further. And as we being one of the leading med devices players in the country, like what are your thoughts around it? So somewhere around that, so you can kind of go in whichever direction you feel like. Is that okay?
Yeah, absolutely. And how do you do it? Do you talk about it, or do you present something? How do you do it?
I think just talking would be better, like for the other CI forums as well, right? It's like, though an hour and 15 minutes looks a lot, but by the time everybody ends up speaking, I think it's towards then it's a mad rush. So probably I'll make a brief introduction, introduce all of you real quickly if that's okay, and then we can get into the questions. And I have some selected questions for the policymakers as well. And yeah, and then we'll see where we go. If we have time towards the end, we can look at questions or counter questions, and feel free to chip in wherever required. That's okay.
Sure, Manoj, sure.
Thank you.
Good to know that you have joined Boston Scientific.
Pleasure. I don't think for whatever reason our roads haven't crossed. But look forward to catching up with you in some time.
Yeah, absolutely. It'll be great to catch up with you.
And Prashant is joining us from Medtronic. He runs the MIT, the Minimal Invasive Therapy Group for Medtronic.
Hi, Prashant.
Hi, Ganeshji. I lead the surgical side, but it's quite interesting to try and meet up with colleagues on the interventional cardiology side. Both Manoj and yourselves, I used to be with Cordis for nearly a decade before I got onto the surgical side. Hey, we have another friend of ours.
Hey, Shishir.
Hey, hi everyone. Hi Manoj. Hi Prashant.
Hello, Gopal. Ganesh is there, I think, and Dr. Arpit.
Hello, Mr.
Prashant,
Agrawal.
long time.
Long time.
Good afternoon, Manoj and Kishore. Hi, this is Swati from CII.
Hi, Swati. Thank you. You've been very active since yesterday.
Crazy 2 days for you, I'm sure.
I'm just glad that I think these discourses are very, very important, and the discussions are so strong. We'll be able to give good, reward to the government on this. That's most important.
Hello, Dr. Gopalji. How are you?
Hello, good afternoon.
Good to see you again.
Good afternoon, Dr. Gopal. See, it is interesting to see all the cardiology guys here.
I was just saying exactly that.
I hope it is not by design, Swati.
Technically, now I'm surgical completely. So
what? You represent Medtronic.
Technically.
Okay.
Good afternoon, Mr. Gopal.
Good afternoon.
EJ will get a queue when you're live, right? I guess, and we should be on time. I think most of the panelists are here, except for a few of them.
Certainly, Manoj, we're just checking Sonali also. If she can join, then we'll let you know.
Okay.
Hello. Manoj, you have 2 minutes more. I'll just call Dr. Sonali, who's not picking up the phone. In case if she joins, she can join later also.
No problem. I'll keep a lookout for her.
Yeah, okay.
Good afternoon, ladies and gentlemen. We are joining the plenary session for evidence-based policy making, driving the MedTech sector growth in India. The session is chaired by Mr. Manoj Madhavan, Managing Director, Boston Scientific India Private Limited. Welcome, Mr. Madhavan. The panelists include Mr. K. Madan Gopal, Senior Consultant, Niti Aayog. Welcome, sir. Dr. Sonali Rawal will be joining shortly from WHO India Country Office. We also have Mr. Arpit Bajpai from the GEM platform. Welcome. Mr. Prashant Krishnan, Head of Medical Surgery Therapy Areas, India Medtronic. Mr. Ganesh Sabath, Chief Executive Officer of Sahaj Anand Medical Technology Private Limited. Welcome, Mr. Sabath. And Mr. Shishir Agrawal, Managing Director, Teremo India. I now give the difficult job to Mr. Madhavan to take this panel discussion forward. Over
Thank
to
you
you,
so
sir.
very much. Very good afternoon to all the delegates listening in, and a very warm welcome to my fellow panelists who are part of this very important session of evidence-based policy making, which is essential for driving the medtech sector growth in India. This session can't be more timely, than now when we are at the back end of battling a pandemic. We're still dealing with it, and there's an increased focus in healthcare delivery, in medical devices, in pharmaceuticals, the entire healthcare chain, and a lot of policies that the government is trying to kind of come up with, propelling the growth in these sectors. For today's session, we would specifically focus a little more on the medtech sector growth, which is still a very early stage in as far as industry development is concerned, and India is still heavily reliant on imports as far as critical technologies are concerned. The government of India has got a very ambitious vision of growing the medical technology space in India from a 11 billion market to a 50 billion market over the next several years, which is extremely ambitious. Is it possible? Certainly, yes. Is there a demand? Certainly, yes. Do we have patients who need to be treated, who need to have access to cutting edge technology? Yes. What is that spice? What is that magical spice that would really make this all work together? It is evidence-based, robust policy making, which will create the ecosystem for infrastructure development, for investment, for R&D, for development of medical technology, for manufacturing and delivery, so that eventually the patient at the end of the chain gets the maximum benefit. Since yesterday, we have had some very interesting sessions on the CII platform for the Global MedTech Summit so far. And we have heard a lot of policy makers, a lot of industry colleagues talking about ease of business, talking about the strength of digital, talking about data, talking about harmonized standards, everything that is very forward-looking, very encouraging for people who are in the sector, whatever level of stakeholder management that we are trying to do here. So very pleased to kind of chair this session. Thank you, CII Secretariat, for the opportunity. Before I go and start asking some questions to our distinguished panelists, a couple of words on evidence-based policy making. So what is evidence-based policy making? It is about making policies, decisions on projects, programs by placing the best available evidence from research, which is conducted at the heart of policy development. It also makes very explicitly known what is the scientific evidence on the basis of which policies get created. In contrast to opinion-based policy making, I guess evidence-based policy making needs evidence at all stages of the policy cycle to define the issue, to shape the agenda, to make the choice of action, and ensure the desired outcome is kind of monitored in a very objective and measurable manner. It also sets up methods which informs the policy process rather than aiming to directly affect the eventual objectives of the policy. And I guess that would probably be the heart of today's discussion for the next 60 minutes or so, when there are so many things to be balanced, in terms of what the eventual objective needs to be, what is the political will, what does the evidence say, and how do we ensure that India is strongly set on the path of self-reliance as far as medical technology is concerned. While I'm sure that people who are listening in and my distinguished panelists would agree that evidence-based policy is the way forward, I guess it is easier said than done, because the prerequisite for evidence-based policy making is robust data, trustworthy data, good quality data that comes in a timely manner. And I guess sometimes, especially in a crisis mode, that becomes a major challenge. However, having said that, We need to use the evidence in decision making to make sure that the evidence that is used is unbiased, rigorous, so that communication transparency becomes easier, and we can move together as a nation to ensure that access to cutting edge technology is available for all the patients out here. Without further ado, I would like to welcome my distinguished panelists one more time, and probably jump right into it. We have people from the policy making side, from WHO, from the procurement side, and some very dear industry colleagues as well. So Mr. Madan Gopal, if I may put you on the spot and probably ask the very first question to you. You are at Niti Aayog, at the heart of policy making. How challenging or how easy it is to create the necessary evidence required while you're looking at policy making? What are some of the challenges that you face, and what are some of the inputs you'd like to provide our industry partners who can help you in the endeavor in bringing evidence based policies? Over to you, Mr. Madan.
Sorry. Thank you, Manoj. So, I thank CIA for giving me this opportunity to interact and share my views and thoughts. I agree that for making policy, one of the prime and important thing is data. But it's not the data per se, but how to use the data for evolving a policy which can benefit, which can see how it would be a win-win situation for others. Because the whole focus for making from a policy's perspective is how it will benefit the beneficiaries, how it will reach the beneficiaries. Apart from reaching the beneficiaries, how it will be a win-win situation for the industry, for the providers, for the others in the universe of that. I'm just citing an example because COVID is a very good example. How the things have shaped up. When this pandemic started, there was hue and cry that all the people, we would be requiring so many ventilators, so many things would be required. But once it comes to the actual installation base of the ventilators in the country, it took us a lot of time interacting with all the ventilator providers to arrive at what is the installation base, how many equipment have been supplied, and how many of them they are installed. It took us a long time to arrive at that kind of thing. That throws importance on the availability of the data. Once the data is available, it needs to be made accessible also. Data is available, but whether it is accessible or not, that's a question which we need to ask. We relied on the census data, that is a National Health Resource Repository census, which was currently going on, to find out what is the actual number of ventilators which we require to cater to. Because at that time, with in absence of a very clear-cut treatment modality, it was supposed to be severe acute respiratory syndrome. For that, ICU admission is more or less warranted at that time. I'm talking pre 2020 April. At that time, there was no concept of how the disease will evolve. Now we have matured enough. That's a different thing. At that time, data was required. The resource repository, which was very resource-intensive exercise, a census of all the health institutions, all the facilities, equipments available, everything was done. But that data was also put to use, but how much reliable it was, we don't know. Second was how to get information from the installation database of all the providers who have installed that thing. As a result, you have seen that picture which was thrown by the ministry that so many ventilators are available in the country. So having arrived at thing, if data access, data availability, good quality data was available, we could have saved 2 months' time at arriving at a decision. So I'm just highlighting the importance, if a good quality data is available, how the decisions can arrive, because that's a policy level thing. The moment a policy decision is taken that we require ventilators support, that needs to be provided. Then the other things, how many are required, where they are required. For that, this was supposed to be done, and as a result, lot much time was consumed in arriving at this kind of figures. That's one thing. Another, how we have come to the as a pandemic progressed. The another treatment modality, because the system was overwhelmed, the virus overshot the pace of the preparedness levels which was being done by for the beds and other things. It overshot the our preparedness speed. As a result, some of the days the system was overwhelmed. But side by side, the data was available that what data was available, the experience which has shown that 80% of the patients, they can be managed with a supervised kind of care at the home level, with the aid of just monitoring the oxygen saturation. That evidence was there. Now, there were other methods of determining the oxygen saturation level, because it has taught us that as the disease progresses, there's a drop in the oxygen saturation levels, and if there is something else, some equipment is available, then we can always monitor and supervise that patient. That kind of research evidence was available. Then based on that, some certain confidence was gained. That means, yes, we with the small pulse oximeters, and by measuring the temperature and the oxygen saturation, the patient can be monitored, patient can be managed, a patient can be supervised at the home level. And that has been a very game changer. We can say that we have been able to at least overcome that catastrophe during the month of April and May. Had it not been this kind of evidence which was available in the form of that use of small technology gadget or equipment for doing this home-based care, so then we would have seen the things which are happening in the other parts of the globe. So that kind of need is there. That means, nevertheless, the bottom line is that for making or arriving at any policy decision, we require a data which is dynamic, and at least it is reliable. If I'm getting data from the industries, that should be reliable. That should be data which was coming from the other sensors. We have to match the data with the installation base. But there should be a mechanism how to converge both these things. If you have sold a product, and if a census is done, you have sold 90,000 ventilators, but the installation has only happened for 40,000. Where are the 50,000 ventilators? That kind of difference should be available. Had it been available, then we could have the time which was consumed in arriving at that kind of decision, we could have shortened that time, and we could have taken other measures rather than investing more time on that. That's why the importance of data-driven, evidence-based policy planning is very, very important. Over to you, Manoj.
Thank you so much, Dr. Gopal, and you bring in some very important, pertinent points, right? One is on the timeliness of the data, and to make sure that the data is reliable. And it's not just that we have the data, like how do we put it to good use and ensure that it kind of reflects into the policy making, I think is very, very critical. On a quick thing on the COVID response, Dr. Gopal, as you rightly mentioned, this was crisis mode, totally unprecedented. And I guess it was not just us in India who were caught unawares. I guess pretty much in the rest of the world, the virus outpaced the preparedness. So I guess these are unprecedented times. But a quick follow-up question to you, Dr. Gopal. Pre-COVID times, or let's say whenever COVID gets to an endemic stage, sometimes there is a lot of data available within the different ministries and secretaries, right? But we kind of, how do you think, as Niti Ayog, how are you kind of bringing in the data which already exists, within the different ministries, and how do they talk to each other? Do you have any views or thoughts on that, or how that can be improved upon? Because several times we realize that the DPIIT has something, or the DOP will have something else, and you have something else. But how does it all kind of play in along? Is there any measures that have been taken in the recent past, especially given the unprecedented situation?
You think that Manoj, the very important aspect which you have raised, because the thought process, if you have seen how the ideas generate at one place, one corner of the globe and the other corner of the globe, you have seen that people down in the southern hemisphere and the northern hemisphere, they have the ideas at the same time. This kind of idea is also being worked on. The data which is available in the different ministry, we are having a DMA vertical at Niti Aayog, which is working, and we're trying to bring all the data in one platform so that whatever data is available, so we can at least triangulate the data and try to see that how one data can be seen from a different angle by the different verticals. So that exercise is already going on. They're in the different. This is handled by our DMA vertical, and they are already working on this, bringing all the ministries' data together, so that in one platform they can have access to all this information. The other modalities will be worked over from them. Apart from that, if you look at the health ministry's data also, they collect data on malaria, they collect data on TB, they collect data on the surveillance, they collect data on everything. NHA data is also coming. So they started a process way back around 7-8 years down the line. They have started the integrated health information portal, in which all the information from all the programs, they would be riding on a single platform, and through a unique identifier, all this data would be talking to each other. This that is being implemented, and slowly you will be seeing that this would be increasingly used for generating reports and generating certain intelligence and other things that would be increasingly used. Nevertheless, these thoughts which is coming from the industry that has already been implemented in the form of the integrated data portal, which is which is evolving at our Niti Aayog, as well as the integrated health information platform, which is coming up with the ministry, in which PMJ data as well as the other data of the ministry, they would be talking to each other, and you would be seeing a unified portal in the coming days. So it is in pipeline, and to add sugar to this, you are having a national digital health mission, which envisages to digitalize giving a unique ID to the health institution, giving a unique ID to the medical professional, as well as electronic health record to the doctor, to the patient. And through these electronic health records, in the coming years, as we have stated in our Vision 2035 document, in future, the surveillance activities would be based on the health events, which would be generated through these electronic health records. That's the kind of vision which we are having. So that means the health is being taken care. All the portals which are being managed by the different government departments, they would be coming into a single portal, so that whatever, once they come together, then the next step can be the improvement in the quality, improvement in the accessibility to all, and bringing in more accountability towards submission of this data. That kind of thing is evolving, and in the coming days you will be seeing more of this kind of news that these things have come, this thing have come. Over to you, please.
Thank you, Dr. Gopal, and that is very, very promising and very encouraging to hear, and a lot of progressive steps already being taken. You talked about the integrated data portal, where ministries will talk to each other, exchange data, seamlessly, which is very encouraging. And definitely the National Digital Health Mission, I think it's a revolutionary, to track the patient data from a very early stage, surveillance and everything, put together. All that are extremely encouraging steps, and I'm sure, as you said, that this direction is forward looking in the right direction, and I'm sure that we will see a lot more seamless transfer of data and how we use it in the right way. Thank you so much, Dr. Gopal, for your thoughts. Moving on to a little bit on the procurement side now, we have Mr. Arpit, who's joining us from GEM as well. And the government e-marketplace is again in the process of revolutionizing how government procures, on a mass scale with absolute transparency. Bringing it back to medical devices, Mr. Arpit, medical devices is complex, it's huge. On one side, you have low-end consumables, and then you have implantables, you have IVDs, you have diagnostics and high-end capitals at the very end. What are some of the data that as GEM, you're looking at, to make the purchase process a lot more seamless and buyer and seller friendly? And what are some of the examples you're picking from, the rest of the world to kind of make GEM, much user friendly? Over to you, Mr. Arpit.
Thanks, Manoj. Just to start with the GEM as a national procurement, like a public procurement portal. Just to give you a brief idea about the MedTech domain, which I'm dealing with as a director for category management. We have approximate around 2000 plus categories for the medical devices, including drugs also, particularly with the PSUs from the government. We have like a domain starting from imaging, the high-end product, capital equipments, and going to the surgicals, consumables items, and including the implants. So we have a whole horizon of the categories, and we are still making the categories on the request from the buyer side as well as from the seller side. Give you one more example is of the due to this pandemic, we have more than like specific categories for the COVID scenario. We have make it visible through our specialized homepage where the new functionalities for the ease of procurement related to the COVID items, where the delivery period has been shortened to 2 days. And eventually we have generated new features like prioritization of the category creation on like a high priority because due to the pandemic condition. And currently we have more than like under the COVID banner, we have like 300 plus categories, including the product and the services part. And we always guide the buyers and sellers to for this for these items. They can really take the advantage of the facilities we have given. And for the categories which are still not available on the portal, there is a provision of custom bid where the products and services bids can be uploaded and the buyer specific requirement can be published and the procurement can be done without any hassle, with transparency and with efficiency. And addition to that, we have engaged the buyers with giving them more flexibility of like 5 additional technical parameters, which are not mentioned in current categories, but they are very specific requirement from the buyer side, just to give more leverage to the buyers. And also we are very much open for the feedback from the industry as well as from the buyers to introduce new functionalities or provisions which are very deemed to appropriate to according to the policy to be accustomed with the current procurement platform we have. So just a very brief idea.
No, thank you so much, Mr. Arpit. And it was actually one of my follow-up questions, which I already kind of talked about. It is very nice to know that GEM is open for feedback from the industry, right? So, is there any systematic way you're looking at it? Because evidence at the heart of evidence-based policy making, it's not about just generating some evidence, making the policy and forgetting it, but to ensure that you continue to gather evidence to make sure that it is working the way it was supposed to, or in terms of the desired outcome of whatever policy we started out with. So if we can touch upon a little bit about, and GEM, the complexity is tremendous, as you rightly mentioned, and thanks to you for, shortening the supply chain response time for critical equipment, especially related to COVID. Sincerely, I think the nation benefited because of that. But from a feedback gathering mechanism and in terms of response, how do you systematically go about it? Or do you have any thoughts in terms of how you want to do it, once things kind of limp back a little bit to normalcy, Mr. Arpit?
Yeah. So just to give for normal categories which are currently existing on the GEM portal, we have a mechanism, or all the sellers have the request management system, or the RMS we call it, where they can request for the maybe the upgradation of the category. Upgradation is requirement because there are new technologies evolving in different domains of the medtech industry, as well as we have very unique features called startup runway, where the startups specialize in like health tech or maybe life sciences technologies. So they can directly upload their product. These features are enabled to make the process online, transparent, as well as to make it on a fast paced manner to address these. And also regularly we are conducting a consultative committee meeting involving all the buyers as well as the sellers, because these are the two major stakeholders for the procurement process, and different categories which are under the process of creation or even in upgradation. We take regular feedback, and this process is like every day is evolving. Yeah.
Thank you so much, Mr. Arpit, for that. And it is, music to, I guess, all our ears when uh, uh, somebody from GEM is talking about ensuring upgradation of technology, ensuring the access to the latest technology is available, and there's a provision for doing it. And the fact that you're conscious about it, I think it's very, very encouraging, because at the end of the day, whatever said and done, we need to ensure that the latest technology is available to treat the patients in the country. So that is the baseline. And over a period of years, it is a continuum. And I do fully understand that India is heavily dependent on imports as of now. But in due course of time, the way we have done it very successfully in some of the other sectors, we will also achieve self-reliance here. But access to technology is paramount, and we need to ensure that is there. And the second thing I also talked about was the startup stream. Again, extremely encouraging. There's a tremendous focus, the government of India is putting it on startups, and I guess there's no other more exciting sector than the MedTech sector as of now. Thank you so much for your thoughts, Mr. Arpit. We'll come back to you. Moving on to my industry colleagues now. Probably we'll start with Shishir. Shishir, your thoughts, on the role of evidence and implementation of policies, specifically around the health delivery, and what do you think? How do you think the government and the medical technology, the industry, can come together to look at evidence to create a role, for advancing technology and innovation? Over to you, Shishir. You're on mute, Shishir.
You're still not learning. Thank you, Manoj. And first of all, I would want to thank CII for creating this forum and this conference and the panel, and a very apt subject, evidence-based policy to drive MedTech sector. And I believe there are many ways to look at it. Evidence-based policy is a very vast subject. I will try to restrict some of my thoughts around public health delivery, and maybe just skim over a role of MedTech and the government. And we all know that India has had a very strong policies for health over last many years. If you look at it since independence, our health policies have been based mostly on social causes, whether it be immunization programs, whether it be mother and child health, etc., etc. Only in the last 4 to 5 years, you'll see there has been a very strong desire to make healthcare more accessible to the larger population, whether it is through the national health policy, the PMJAY, etc., etc. However, most of these policies have been made with very strong, good intentions and have brought in very encouraging results. However, there is an important aspect of application of evidence when we have to further improve delivery of some of these policies, delivery of healthcare services. How do we bring more accountability and governance so that the facilities reach and are utilized by the larger section of our society? An important aspect is collecting and analyzing different data that will help policymakers like Dr. Gopal. He spoke about integrated health info portal, the DMA vertical, etc., integrating data from different departments. But I'm certain that main sources of all these data are primarily hospitals across levels, whether they are public or private health systems, whether they are different government surveys, whether they are insurance data, etc. However, there are challenges to capture quality data, and more than that, integrating it and then report it in a manner that will enable, again, robust health policies. However, adoptions of health IT systems, etc., staff training, I would say educating our patients also for the reason about collecting data. And I'm sure many of us, even today, when we go to any hospital system, we ourselves sometimes feel, okay, why am I giving so much data? So there needs to be an awareness around it. How do we bring that data in a more centralized manner? How do we improve analysis of the same? I don't know, maybe use a lot more technology around it to build more stronger evidence, which is much more meaningful also. This will not only help health services, but I believe that it will help all the policies and all the intended beneficiaries to avail of all of the benefits completely. Uh, Again, this is more around data. Switching gears, if I have to speak about role of MedTech, we all know innovation is important for improving health outcomes. Over many years, innovation has been going at a breakneck speed, more so in medical devices also. There have been ongoing advances, whether it's on the product side, on delivery side. Today, we all speak about remote monitoring, connected health, etc., etc. In coming days, we will see a lot more new technologies which we have not even thought of. They will further simplify, they will further improve health outcomes. It is about time that we start looking at medical devices from different lenses. And Manoj, you spoke about low-tech devices, etc. So the way I look at it, low-tech devices that are absolutely necessary for basic care, innovative devices that will substantially improve way things are done today, and also complex equipments that will drive predictability, efficiency, and also new therapy interventions. Now, again, what is the way of differentiating them? Today, again, on a lighter note, all of us feel about, okay, there is a price cap around the corner, there is a PLI, there is a PPO, etc. So is there a case for health tech assessment, a board which can push in new innovative technologies without compromising on cost, but at the same time ensuring that all the supports are backed by evidence, the claims by organizations bringing these technologies, etc., are given the right platform to flourish rather than be ambiguous around it. This will truly further the cause of bringing latest tech products and also provide fair exchange of value between both the sides also. Again, evidence is going to play a very strong role in it. And from this platform, I can request different departments to start considering looking at some of these areas which will enable us to push in latest technology products into India faster than today and ahead of time. Again,
Shishir, I think we lost you, or is it just me?
etc. All of these are in the right direction. But at the same time, I would say these are very early days. We should continue to monitor the adoption, the progress and success, and maybe again generate evidence for a case to make further changes around them so that they become a lot more effective. Again, in closing, I can only say that evidence-based policy approaches are very important. We are taking steps around that as a country also, as an healthcare system in India, and it can dramatically help elevate the standard of care in India and overall improve economic performance. I hope I've been able to address your question, Manoj.
No, thank you so very much, Shishi. Some very good points brought forward. Uh, as you rightly mentioned, schemes like PMJ, National Health Mission, they're all done with very good intentions, and we're proud that we have some of the largest, public insurance schemes in the world happening in India. But as you rightly mentioned, for it to really kind of have the desired impact, that the government envisioned, with the more and more you look at policy, the more and more you look at health technology, the more and more you put in health economics into it, I think the better outcome will be realized. You also brought in a very, very important point, which is very close to my heart as well, in terms of ensuring the latest technology is available in the country, right? And to look at a special route where looking at health tech assessment, evidence-based, introduction of devices, so that Indians or the patients in India are not getting second-hand or third-hand treatment. What is available anywhere in the world should be possible technically in India. And some of us have lived and worked elsewhere as well, outside in India. I can say with a lot of pride and confidence that the practitioners in India, the system in India is on par, if not better than anywhere in the world for that matter. But the individual can only be as good as the tools he or she possesses, right? And we need to make sure that the technology is available. And you said it summed it up very nicely, Shishir. You talked about a fair exchange of value, and to make sure that technologies reach India faster than not. And India is a preferred destination to make sure as a hotbed of innovation. And eventually, innovation, the usage of innovative products will propel further innovation and further R&D in the country and further manufacturing in the country. So I guess all very fair points. Thank you so much, Shishir. With that, I would like to move on to Mr. Ganesh Sabath. Through here, the other side, Mr. Sabath runs one of the largest and most innovative medical devices in the country. Mr. Ganesh, what, according to you, have been some of the policies, recent policies that have been brought out by the government, and how do you think evidence-based policy can really propel the domestic industry to continue on the path of innovation in India, and eventually help us realize the vision of self-reliance? Over to you, Mr. Ganesh.
Thanks a lot, Manoj. Thanks for the nice word. I really appreciate. So first of all, I think we have been through a COVID time. I think, and there are a lot of challenges that we have seen. And as you have rightly said, probably this is the right time to talk about evidence-based policy. How it can help, and I think if I analyze from where India has come in last 10, 12 years to having PMJ policy, having 300 million population coming into healthcare, that's pretty big. I know everywhere I go, they talk about it. They talk about the future potential of healthcare India is creating. This is really, really big, and congratulations to the government for such an initiative. Now, with that, government has taken up a big financial burden, and that big financial burden can be supported by evidence-based policy. That now you have asked me to talk about how it will benefit and how it benefit India to become a large medical device player. So I think the first step in that is to really, it will bring a financial discipline. So if you look at the current challenges that we have, as rightly Dr. Gopal has said, we don't have the knowledge to make the policies. So by creating evidence-based policy system, you will seek those knowledge. It will give medium to create optimal clinical care for the patient, and also it can be the cornerstone for policy making. Today, when you go for a stent price cap, we talk about different products, different benefits, and government is absolutely they have categorically told that they don't have the ability to evaluate any of these stent differences. So it can become the cornerstone for policy making. At the same time, healthcare is an innovative field. As we can see in COVID, in 1.5 year time, the kind of knowledge that we have gathered. So that means the innovation is pretty fast. If you don't have an evidence-based policy, if the new evidence is coming, you are not going to change the policy. You are going to follow the same thing. So to promote innovation, you need to have evidence-based policy. The other point, if you look at currently India-wide, the treatment, there's no uniformity. The treatment in North will be different than treatment in the East, in West, and South. But the need of the hour is to have uniform. And how will you bring that uniformity? That will be again brought by evidence-based medicine. The other critical point which India is struggling right now, and probably different parts of the world they are struggling, is how do we bring, reduce the unethical practice? How do you bring medical professionalism? If you have an evidence-based policy and you are able to put guidelines, I think that will reduce the unethical practices. So I think if you look at the region, it's very compelling and it's very obvious that we should have it. And India has come a long way to have a scheme like PMJ, but to make it much more effective, to make it patient-centric, we need to move into evidence-based policy. Now, coming to the point, the second point that you have said, that how it will help companies or India to become Atmanirbhar. So, I can talk about our industry, that medical device, the product development is costly and time consuming. one product is going to take around 5 to 7 years for development, and the kind of investment that we make is huge. Without any policy framework, how do we target innovation? If the policy is there that patient benefit is the utmost importance, that's what we promote through evidence-based policy. Our innovation will be targeted towards that. So it will help the companies also to aim and target in the right direction. The other point is, the medical device companies, and Dr. Gopal again talked about data. A lot of the time, the medical device companies, they create the data. When you do clinical studies, when we do randomized trial, a lot of meta-analysis comes through, and those are the evidences that you need to create those policies. And if you promote that, we will look at evidence-based policy to come up with guidelines, the companies will be compelled to do a lot of clinical studies. And that essentially not only help Indian companies, any healthcare practice, any patient in the world, that will help. And if the Indian companies are at the forefront, absolutely, they will get benefited out of that. SMT is a live example of investing in clinical studies and globally getting benefited out of it. The other point that I would like to, give some practical examples. Every one of us know that now you have new technologies like TAVI, and TAVI, it's well established that in high risk patient, even medium risk patient, TAVI is much better than a surgical valve. Now there is no policy, right? There is no policy for the government having this evidence, and TAVI is the next future in medical device, or any valve, structural heart is the future. So without having this policy, how much we can invest, how much we can develop this product. Similarly, if you look at peripheral intervention, India has got a lot of peripheral intervention patients. A lot of them are getting treated just through medicine because there is no policy, nothing behind it to promote it. Even if you look at, let's say, if I can give another example, the current in the stent, just in the ESC conferences and before that, there are a lot of meta-analysis that has come that ultra-thin stent platform is much better, giving much better result. But, there is no policy here in India, so the doctors are not going to follow, neither the patient will going to get those benefits. But if you have these things where we can have this kind of mechanism, there is a nodal agency, let's say, an independent agency. It cannot be any political reason that we are coming up with policies. It has to be independent, and it has to make decisions based on meta-analysis or randomized clinical trial. It cannot be just a simple study and which then be questionable at multiple front. And you need to have those kind of people who can drive it. I think if we can do it, it will take India to the next level to become really Atmanirbhar. But not only that, really create a niche for itself in the international market.
Thank you so much, Mr. Ganesh, for those views. You bring in some very valid points to say that, you need to start with an evidence-based policy making and then keep continuing on it to make sure that, that is the norm. Unless you start with a base where evidence is used for policy making, it will never get to a point where at some stage, suddenly some evidence comes up to change the policy because it was never, began in the first place. Very valid point. And I think, something which you mentioned is, again, very close to my heart is in terms of treatment uniformity and clinical protocols to begin with, right? One is on the infrastructure issue for sure, but as you rightly said, even in terms of clinical protocols or treatment options and everything, if there is an independent nodal body which can be kind of clear coming out with guidelines, as it happens in some of the other nations, I think it can give a lot more transparency, I would say, in terms of, how some outcomes are kind of taken care of. And very rightly said, employee evidence-based policy making not only just ensures in good outcomes as such, but also propels innovation and clinical studies, which is essential. Like most of the clinical studies that we rely on in the healthcare comes from, the origin is outside of India, which shouldn't be the case. So I guess these are very valid points. Thank you so much for your thought. Switching gears here, moving on to Prashant. Prashant, I know, introduction of products and therapies is a very, a very close topic for you as well. Can you touch upon why, or evidence-based policy making is essential while we look at introduction of products and therapies in India, please, and what can be the pitfalls for not doing so? Over to you, Prashant.
Thanks, Manoj, and thanks CIA for the opportunity to try and speak on a very interesting topic. And it's also interesting because I can contrast how things have actually happened over the last decade and how things have suddenly started moving in a far more structured and a direction which can actually help the medtech industry really propel itself and patients to try and really benefit in India. I'll give an example, Manoj. 2012, there was a study that came out, which was way back there, and talking about the link between bariatric surgery and diabetes remission. Now, while that data came out, it took nearly a decade before we could actually have the IRDA come up with a policy of reimbursing patients who get bariatric surgery done. Contrast that to the situation that we faced in COVID, and Dr. Madan Gopal talked about the entire ventilators piece, which is quite close to my heart as well. It took very little time for the Niti Aayog and the entire bodies in the government to come up with what should be the right specifications for the ventilators which can be used in the COVID patients. Now, that in my mind is a significant transition that we saw. And it is important because only when you actually have the policy makers clearly looking at data points, will you get the right products and right technologies into the country. Also, we are also looking at a situation where not just, let's say, but also in terms of performance. And when I say performance, I'm talking about usage in patients, the data associated with it is all that needs to be trying to put together and presented for policymakers to take the right decision. So it's not about just making it using the XYZ product category, the X component. It's also about how it performs in the real world. And that's something which I think the government has got a far better understanding on. And as the things kind of evolve in the next few years ahead, my sense is between different bodies that are on this particular process will get far better at this and will get far more structured. For example, Arpit was talking about the fact that the GEM portal is actually giving an opportunity to the industry to try and represent. What is it that we need to try and do as an industry? We definitely have to make sure that GEM understands that not only are we looking at what exactly the product or the category is, but also what will be the performance which will be necessary for it to get approved and get to the patient and get to be used in the patients. And I think it's our responsibility, but also for the policymakers, it's their responsibility to really see the data that is put together and make a compelling enough case of why one particular therapy, one particular product, or one particular technology needs to be leveraged more for the benefit of patients. The other part of the piece, Manoj, is, and then Shishir also mentioned it, we're talking about what was the past, we're talking about what's present, but you look at what is going to be the future. In another half a decade, we should be seeing significant amount of procedures getting done with robotics. Do we have a policy around that? Is there enough data points available on that? Not really right now. And if you are going to be expanding significantly and doing those procedures, that data point needs to be made aware to policymakers so that a structured and a well-defined manner of how some of these new procedures which are going to be done in India will be approved for and will be paid for. So that's the second part of the piece. The third is in the area where the responsibility lies with us as industry. For years, we've been talking about what's called the Indian experience. I think we need to move beyond the fact that the Indian experience is what counts. Obviously, a lot of you have mentioned the fact that we have the best doctors, the best healthcare infrastructure created, but it is not experience. We need to put together compelling data which is coming from India by different teams of either institutions, groups, or industry per se, and really put together a really strong, compelling India data point, which will really help the policymakers take a decision. For years together, we've actually relied too much on data which is coming in from the outside. It's not data which is relevant to India. And the vaccine example is a perfect example where a lot of the data that came out of India was used to try and take some decisions, which has actually benefited patients at large. My final point will be that as we're looking at scaling up in innovation, coming up with new therapies, new technologies, it'll be imperative that the policymakers look at the data points, use those data that is available from different sources to really take the right decisions, which can help the med devices industry really propel itself, become not just a provider for devices in India, but also for the world. And that's something that is a possibility, but it'll only be dependent on how exactly the right data points are used to take decisions and policy making.
Thank you so much, Prashant. Some incredible points brought out there as well. And as you rightly said, I think it's not about the cheapest product or product which looks similar, but in terms of desired patient outcome, right? The performance of product becomes extremely crucial. And I guess that's where medical devices differ significantly from pharmaceuticals, like in terms of product performance and the importance of incremental innovation, how it can significantly influence patient outcome, with incremental innovation. But I guess it needs to be captured, and it needs to be part of evaluation process, introduction, or even from a procurement side as well. And I'll probably request Mr. Arpit to come in with a comment on the GEM portal as well. But let me quickly summarize some of the other points which you mentioned, Prashant. In terms of progressive technologies, right? As you rightly said, we are talking about the Internet of Things. We're talking about remote monitoring. We're talking about robotics and stuff like that. So do we get to a stage where we start looking at the technology and then formulate policies, or are we playing a catch-up game, or we eventually end up playing a catch-up game in medical devices? And that is a reason why it is so essential, going back to Shishir's point on how do we ensure the latest technology is available. Unless you see the technology, unless it gets used in the country, policies don't get formulated, right? People wouldn't even think about it, and which means essentially you would miss the bus, by denying access of technology coming in there. And I guess all of us have touched upon it. Mr. Ganesh talked about it. She should talk about it in terms of the Indian experience. I guess the disease states and the anatomy, whatever you want, everything you want to put in together is very unique. India is unique. The disease states here are unique. Data needs to be generated locally. Data needs to be assessed independently, and those needs to be robust, reliable data, and not a data that is generated for a specific outcome in the policy making. So very good points. Thanks, Prashant, and I'll come back to you. Mr. Arpit, if I can, get you to just quickly comment. I guess Prashant brought a very valid point in terms of how do you link quality or performance of the product back to the procurement side. Now, I do completely understand that we are not living in an utopian world, and that we're still making significant progress in terms of e-marketplace. But is there a vision at some stage to kind of try and link back the performance or the quality of the products that gets purchased through GEM? Any feedback mechanism that can be then used to kind of look at categories differently? Over to you, Mr. Arpit.
Surely. So the most crucial point is the quality of the medical devices, because it's directly involving the patients. So basically, we have the mechanism of incident management, where the buyers, which are procuring through the GEM portal, they have also a dashboard or a RMS system where they can raise the incident based on the product they have received it, and they can raise the quality issues, maybe all type of issues related to the product delivery, or maybe quality, or maybe any fake product, anything. So they are a provision in the incident management policy, which is there available on the GEM portal. And according to that, we will analyze that issue, and based on the policy, we will then, the penalties are on there on the sellers, which can be the reseller or maybe the OEMs. So there is a provision on GEM, and we rigorously and we are very ethically, we follow that process, and that is totally online, and where both the stakeholders are like they are having a visibility of the how the whole process has been taken place. So there is already. And also one point I want to also give, that based on the new technologies which we said, there is also a provision of vendor like exemption are for the ICMR approved or products. So ICMR also has given and supported us with the exemption for the crucial product or very critical product for the COVID related medical devices or maybe diagnostic products. So that is one part which I want to also emphasize.
Thank you so very much, Mr. Arpit. And again, it's very reassuring and encouraging to note that there is a continuous feedback mechanism, and I'm sure it will only keep, getting better with it. So one quick question, and I'll probably throw this to the entire panel and probably invite some of you to talk about it. COVID has not been easy on any of us, especially not. And sometimes it's very easy to look back and be critical on how things could have happened better and all that. But having said that, the way the country responded to the challenge has been unprecedented, right? From a place where we were struggling like a year back, coming up with indigenous vaccines, making sure vaccine production is ramped up, going up to 1 crore of vaccination every day, and looking at the healthcare delivery, getting prepared, ensuring the medical technology required for COVID support, be it ventilators or PPE kits, getting self-reliance in that. It's been a remarkable story, and obviously we'll only keep getting better from here. However, having said that, and let me pose this question, many a times when you talk about medical devices and self-reliance in the country, the COVID response is taken as an example, and self-reliance or in PPE kits and ventilators is then blindly kind of extrapolated to everything else which is in medical devices technology, which definitely isn't the case. As some of my industry colleagues also mentioned, it is a continuum. The technology can go anywhere from a basic syringe all the way to a complex artificial intelligence operated capital equipment. But sometimes these kind of data is kind of thrown at, and then a lot of policies come out with. I know it's a slightly provocative question, but any quick reactions from anybody in my panel here on this? What are the pitfalls of looking at certain evidences in a very selective way and then kind of coloring it, the entire world with it? Any reactions? I can see Dr. Gopal trying to hide a smile there. Can I invite you, sir, for a quick comment before I move on to Shishir and others?
It's a very interesting question, Manoj, because during the COVID times, we have come across many people who have come up with the data, painted a picture, coming up with a solution which needs to be tested, with evidence needs to be generated for that. But they came up with the data saying that you take the example that they have done the breath analysis. With the breath sounds, they can diagnose whether the person is having COVID or not. From that kind of aspects to the other aspects also, that if you use this kind of chemical and spray, you can have this kind of protection. So wide variety of that. The bottom line is that do we have a assessment mechanism for assessing all this kind of claims? Though ICMR portal is there, to whatever this cures are there, any treatment modalities, they can apply them and they can claim and they will verify that. But can we have that thing in a very institutional way, so that in future also, whenever such kind of claims are there, such kind of data is there, so that we can immediately verify that kind of things. Second thing is regarding the vaccine you have told. Everybody has approached. It should be taken in that spirit only. During the time when there were diagnostic capacity limitations for COVID testing, people came forward saying that give us a chance and we will just change all the things. But if you look at the figures of daily testing done in the public sector and the private sector, so what has been shown and what has been demonstrated and given, it speaks a lot of discord. That means somebody comes and say that we are having 75% of the expenditure happens in the private sector. We give us an opportunity and we will show you the results. Now from few laboratories, less than 10 laboratories, now we are having 2,800 laboratories which can do COVID testing. If you look at the percentage, daily they are doing around 14 to 18 lakh tests. And see the percentage. The people who have shown a rosy picture, now where are all these people gone? We have to introspect on that. If you are claiming something that I want to do this thing, give an enabling mechanism. This enabling mechanism was given, but where are the results? Where are the results? Similarly, for the vaccination also, people have come forward saying that you allow us to do vaccination. Initially, it was allowed. Policies were changed, policies were tweaked to accommodate all these things. Now there is reluctance on the part of a particular section. So our rosy picture was saying that we are having so much capacities with the data, presentation, decks, everything. That kind of pitch was made. Now, once it comes to the actual deliverance, look at the data. Data speaks for this. How many jabs have been done in one sector, or how many jabs are done in the other sector. So we see that whatever data is being shown, we have to not to claim, because if you look at the projection which the government is making on behalf of the manufacturers. Now we are not taking on the, because the data which is there, as you have rightly mentioned, or the data has to come from the manufacturers and the devices. If they provide a wrong data, and if we firmly believe that whatever they are saying, they would be saying the true picture, they will be giving the true picture. Then if you are carrying out welfare measures as per the data will be given, then you see the chaos which have been created, the issues which have been raised. That means whatever data is coming to us, we should take in the right perspective, do some dig down analysis and see that whatever the person is claiming, whether it is true or not. I can't be upfront sharing more than this, but this is a fact that the contribution is less than 10% or 10% for vaccination as well. If you talk about the production capacity also, that figures, because at the government level, they doesn't own a laboratory, they doesn't own a manufacturing unit for vaccine. Whatever figures are being shared, that after some kind of scrutiny, that has been shared in the Press Information Bureau. So that's why there's a discord between both the two things. You might have seen that. So that means that was, I was smiling that people usually come, they give a rosy picture, saying that I would be doing this thing. Then once this comes to actual execution, then things go here and there. So that kind of experience which we had, now we have to see that how we limit this kind of things. If somebody is coming forward, if he is claiming something, at least he should be claiming less than what he can deliver, and he delivers more than that. That would be a good thing, rather than claiming this much big and delivering a little amount of that. And that would increase the trust deficit, which is already there. So if the private doesn't trust the public side and the public doesn't trust the private side. So if you want to reduce that trust deficit, this kind of data which is shared, you have to see that the gap between what the actuality and what you are projecting is less. So over to you, please.
Thank you so much, Dr. Gopal, for being open about it. And as you rightly said, sometimes in a lot of enthusiasm, data, a very small part of the data gets captured, and then that gets projected and probably doesn't lead to a desired outcome. Prashant, I'm not sure if I saw a raised hand. Do you have a comment, please?
Yeah, I do. Dr. Gopal will remember this also. Essentially, when the specification for the ventilators was made, multiple entities went ahead and said that they will be able to produce. Finally, the ones who were able to produce were ones who had the capability, and the data is something that is important because their capability was based on their experience, their ability to try and scale up manufacturing. The second part of the piece also is when you look at, let's say, data to be a decision maker for driving policy. A perfect example is ventilators. Now, while we make enough number of ventilators, there are multiple segments of ventilators that are required. So while we may have one type of ventilators which we have excess of, the fact of the matter is Wave 2 showed us exactly the vulnerability that exists. Even today, when we're looking at the Wave 3 procurement and Niti Aayog is kind of leading it, you got to understand that the neonatal ventilator support that we have is extremely limited. And hence, the need for actually not taking what's called one point to try and extrapolate and assume that we've actually kind of done very well across. It's not the case. We may have done well in one particular segment, one particular requirement, but that's not going to be possible to be extrapolated across.
Thanks, Prashant. I saw Mr. Ganesh also raise his hand, and yeah, Shishir, I'll come to you in the end. I have something more for you to ask. But Ganesh, did I say a raised hand? Would you like to comment on the topic?
No, absolutely nothing to comment. I think quite like the statement made by Dr. Gopal that there are a lot of challenges right now. In fact, in collection of data, in ensuring that what we speak and what we do. I think from the both sides, and I think the way it's we are seeing a new world right now. I think as we move along, I think things will get much better. Absolutely, ventilator is a great example where a lot of chaos was there in the beginning. But I think these are all learning steps for the industry, for the government, for every one of us, and for us to learn and move forward. I think that's the way to go.
No, very fair point, Mr. Ganesh, and these were unprecedented times, and I guess we just learn as we move along. And more important is to reflect. Like once we've had a sour experience or we've jumped into conclusion using some limited data, how do you make sure the same pitfall doesn't happen? But Prashant, you brought us very important point, and I just want to kind of highlight that before I go to Shishir, is that sometimes medical devices is oversimplified, and as you rightly said, even within ventilators, there are different categories of ventilators which leads to very different outcomes. And we need to understand that it's not as simple as just calling something a medical device and then making sure extrapolating one technology to the other, even within specific categories, right? And I can argue all the way from syringes to whatever complex machines you're talking about it. There are categories, subcategories, different patient outcomes, quality issues which come along. And I guess to all the people listening in, I think that's a very important thing that needs to be considered while formulating anything around the medical devices. But Shishir, I did see a raised hand. I would invite you to comment, and I would probably ask you, the same question. And we have heard this across different forums where the successes of achieving self-reliance in PPE kits and ventilators is sometimes, quickly extrapolated to the rest of the categories, some of which are high risk, high implants, categories as well. I know you've been in the industry for a fair bit, Shishir. Your comments, please.
And again, I was smiling on that question, Manoj. First of all, emergency situations require unprecedented solutions also. So hats off to everyone who achieved, let me put it this way, self-reliance for PPE kits, etc., etc. It is no mean feat in itself. And people who did that, they deserve all the applauds that we can administer also. But at the same time, again, we've seen that in emergency times, many of us have been very opportunistic. And again, this is the lens with which I would like to say that, okay, in one segment we've done good, doesn't mean that the entire category is open to similar experiences. And again, my favorite subject, let's start differentiating between basic medical devices, consumables, etc., basic care, uh, innovative products, complex products, really high-tech products, and how are we going to handle that? And again, achieving self-reliance on many of these things is not very nearby. And that is something that we need to start looking from a very policy perspective. How do we promote that? How do we encourage it? How do we incentivize it also? Because see, even if you look at the government PLI initiatives, etc., it has attracted a few, I say, investments also. But at the same time, we need to understand is that medical device, setting it up, the industry itself from a quality perspective, and I'm sure Ganesh will be more than aware of it, it does not happen in 24 months' time. It takes years and years of efforts. So are we going to look at things in a very short time frame? How are we going to keep encouraging things in that direction till the time they become more world competitive also? But at the same time ensuring that the patient is not shortchanged. So how do we achieve a balance in that? And there is a complete gap in policy in that regard. And I hope that when I'm talking at this platform, the powers that be will take that into consideration when we are creating more policies in future. I hope I've been
Very well.
correct and not offended anyone out here.
No, totally not, Shishir, because see, at the end of the day, when we are talking about a patient outcome, quality of products and accessibility, access to technology, I guess that is something which everybody on this panel and everybody is listening in truly wants and truly cares for. So absolutely not. Thank you so much, Shishir, for your candid comments. I think we are in the last, few minutes. I would like to, quickly summarize some of the very interesting discussion that has happened today. First up, thank you all for candidly sharing your views and valuable thoughts on evidence-based policy making. I guess it is wonderful, and it is very heartening to note that be it Dr. Gopal from Niti Aayog or Mr. Arpit from GEM or all my industry colleagues, everybody, if I can say, unanimously said that it is the way forward. Evidence-based policy making is the way forward. But the trick is to ensure we get data, robust data, in a timely manner, and it is reliable and can stand the test of time. And how do we kind of do this as we kind of moving along? So that is the first thing. Second thing, I think all of you talked about how evidence-based policy can actually propel innovation, which is rightly so, and also can create, what I think Prashant put it as the India experience, because most of the things that we rely on, be it data and everything else around health economics or patient condition, comes from outside of India, which ideally shouldn't be the way moving forward as well. And then it is very heartening to note, the government is taking very positive steps in terms of integrating data across ministries. Dr. Gopal, talked about the integrated data centralized portal and DMA, and which is very, very encouraging. It is also very heartening to note, Mr. Arpit from GEM, though being procurement agency, so forcefully talking about quality feedback and mechanisms to ensure that the right quality products reach the right patient at the right time. So overall, a very, very interesting and exciting decision. Discussion, and I'm sure this discussion would have triggered some thoughts and for the people who are listening in, to see how we can work together, the government, the industry, the private sector, and irrespective of multinational domestic companies, to make sure that the right technology again reaches the right physician at the right time, to make sure that the patient outcome is desired. So that is all from my side. It was a pleasure and honor hosting this session. Thank you so very much for your participation. Swati, I turn it over back to you.
Thank you, Manoj.
Thank you,
and
Manoj,
thank
for
you.
being a great host.
Thank you, Manoj. Thank you, everyone.
Thank you, everybody.
Thank you, Manoj, and thank you all the
Thank you.
eminent panelists for this session. We shall be doing a short break and then request you to please join us for the last session for today, which is on the regulatory landscape for medical devices and diagnostics in India, opportunities and challenges. Do meet us at 4 p.m. Thank you.
Thank you.
Thank you, Swati.
Thank you.
on-demand glucose monitoring that doesn't interrupt life because you're always on. Another life-changing technology from Abbott. So you don't wait for life, you live it.
What is care all about? An endearing smile, a soothing touch, or perhaps the comforting reassurance of an honest commitment? At Polymed, for years, our commitment to provide the highest quality healthcare to mankind has run deeply through all aspects of our ideology, decisions, and work. Care, concern, and love for humanity. Polymed was established in 1995 and started manufacturing operations in 1997 with a vision of providing the highest quality of healthcare to mankind. Since inception, Polymed has been on an ever-expanding journey of achievements, marking key milestones year after year. Our values of integrity, care, ownership, learning and inclusivity puts us in a dominant position in the healthcare industry. Polymed as a brand is committed to continually evolve and innovate products that are proven, safe and sustainable. Our innovations are focused not only on creating value today, but also to prepare healthcare for a better tomorrow. Our varied specialities include infusion therapy, vascular access, dialysis, respiratory care, urology, blood management, oncology, gastroenterology, blood collection system, surgery and wound management, and anesthesia. While our technologies are truly state-of-the-art, our business model is state-of-the-heart.
Polymed is now moving towards its new orbit of bringing more products which are close to clinicians, healthcare practitioners.
Our acquisition of Plan One Health, a leading Italian medical devices company, has further allowed us to expand our horizons, adding focus to in-depth R&D for making highly specialized systems. We are proud to say that today, Polymed is one of the leading manufacturers of infusion products in the world, exporting to an array of over 110 countries. We are Polymed, and we care for you. Our drive comes from our compassion for saving lives and building a healthier society, a happier society. Polymed. We care as we cure.
Dermopenpol Private Limited is the market leader in India in the field of equipment and disposables for the blood transfusion industry. Established in 1985, it pioneered the manufacturing of disposable blood bags in India. Headquartered in Trivandrum, the company employs a workforce of around 1,400 people. Blood Bag Factory makes wide range of blood bags under the whole blood platform. BBF has a capacity to produce 10 million sets of blood bags per annum. The process starts with extruding PVC pellets and tube, flowing through bag sealing to form individual bags. The bags are completed to get the configurations of single, double, triple, quadruple and penta bags using a combination of tube bag assembly stage. The pharmaceutical solutions are filled into respective final configuration of bag. These filled go into primary packing to reach steam sterilization chambers for their terminal sterilization. Secondary packing follows after final inspection and then into required cartons for shipping. The vision of TBCT EMC was to form a team based in India to align with the high-level company strategy to expand innovation to fulfill 24-hour clock functioning. I&D India in its operations have delivered excellent results for the investment made on the facility and resources. The team is in close collaboration with the global associates. The premises is having facilities such as laboratory space and aging chambers, office space for I&D disposables, design quality and regulatory affairs meeting rooms, laboratory and training halls. Medical Equipment Division assembles close to 21 different varieties of products used in the whole blood collection process, starting with blood mixers, RF sealers, donation couches, component separators, component storage refrigerators, freezers, agitators, special purpose scales, water baths for issue of plasma, etc. Close to 4,000 units are produced every year. Sub-assemblies made as per in-house specifications at various subcontractors are assembled and tested 100% before final clearance to customers. We believe in developing good customer relationships. Thermopenpol products are used in blood centers across 75 countries globally. We champion the cause of promoting voluntary blood donation along with other CSR activities. Thermopenpol continues in its quest of unlocking the potential of blood and providing better patient outcomes.
On-demand glucose monitoring that doesn't interrupt life because you're always on. Another life-changing technology from Abbott. So you don't wait for life, you live it.
What is care all about? An endearing smile, a soothing touch, or perhaps the comforting reassurance of an honest commitment? At Polymed, for years, our commitment to provide the highest quality healthcare to mankind has run deeply through all aspects of our ideology, decisions, and work. Care, concern, and love for humanity. Polymed was established in 1995 and started manufacturing operations in 1997 with a vision of providing the highest quality of healthcare to mankind. Since inception, Polymed has been on an ever-expanding journey of achievements, marking key milestones year after year. Our values of integrity, care, ownership, learning and inclusivity puts us in a dominant position in the healthcare industry. Polymed as a brand is committed to continually evolve and innovate products that are proven, safe and sustainable. Our innovations are focused not only on creating value today, but also to prepare healthcare for a better tomorrow. Our varied specialities include infusion therapy, vascular access, dialysis, respiratory care, urology, blood management, oncology, gastroenterology, blood collection system, surgery and wound management, and anesthesia. While our technologies are truly state-of-the-art, our business model is state-of-the-heart.
Polymed is now moving towards its new orbit of bringing more products which are close to clinicians, healthcare practitioners.
Our acquisition of Plan One Health, a leading Italian medical devices company, has further allowed us to expand our horizons, adding focus to in-depth R&D for making highly specialized systems. We are proud to say that today, Polymed is one of the leading manufacturers of infusion products in the world, exporting to an array of over 110 countries. We are Polymed, and we care for you. Our drive comes from our compassion for saving lives and building a healthier society, a happier society. Polymed. We care as we cure.
Thermopenpol Private Limited is the market leader in India in the field of equipment and disposables for the blood transfusion industry. Established in 1985, it pioneered the manufacturing of disposable blood bags in India. Headquartered in Trivandrum, the company employs a workforce of around 1,400 people. Blood Bag Factory makes wide range of blood bags under the whole blood platform. BBF has a capacity to produce 10 million sets of blood bags per annum. The process starts with extruding PVC pellets and tube, flowing through bag sealing to form individual bags. The bags are completed to get the configurations of single, double, triple, quadruple and penta bags using a combination of tube bag assembly stage. The pharmaceutical solutions are filled into respective final configuration of bag. These filled go into primary packing to reach steam sterilization chambers for their terminal sterilization. Secondary packing follows after final inspection and then into required cartons for shipping. The vision of TBCT EMC was to form a team based in India to align with the high-level company strategy to expand innovation to fulfill 24-hour clock functioning. I&D India in its operations have delivered excellent results for the investment made on the facility and resources. The team is in close collaboration with the global associates. The premises is having facilities such as laboratory space and aging chambers, office space for I&D disposables, design quality and regulatory affairs meeting rooms, laboratory and training halls. Medical Equipment Division assembles close to 21 different varieties of products used in the whole blood collection process, starting with blood mixers, RF sealers, donation couches, component separators, component storage refrigerators, freezers, agitators, special purpose scales, water baths for issue of plasma, etc. Close to 4,000 units are produced every year. Sub-assemblies made as per in-house specifications at various subcontractors are assembled and tested 100% before final clearance to customers. We believe in developing good customer relationships. Thermopenpol products are used in blood centers across 75 countries globally. We champion the cause of promoting voluntary blood donation along with other CSR activities. Thermopenpol continues in its quest of unlocking the potential of blood and providing better patient outcomes.
on-demand glucose monitoring that doesn't interrupt life because you're always on. Another life-changing technology from Abbott. So you don't wait for life, you live it.